Okay, start na natin. So guys, bali dalawang part itong discussion natin today. This is the lecture part for that principle and theory, and then later on we will have the methods for glucose. Okay. So start na natin. So this most of the concepts here in these slides are basically biochemistry. So hindi na kayo masyadong mahirapan intindihin itong mga concepts ng slides na to. Okay? So when we talk about carbohydrates, they are the clear source of energy. So kapag tinanong, what is the blood sugar? What is the carbohydrate or sugar present in plasma or serum? Commonly, it is glucose. Okay? So since they are used as an energy source, derangement in carbohydrate metabolism can lead to many physiologic diseases. Okay, and some of these physiologic diseases are familial or they are inherited. Okay, ano yung pinaka-common na na derangement of carbohydrate metabolism? It's diabetes. Okay, so we have classifications based on carbon number on monosaccharides. Basic na lang ito when we say triose, 3 carbon, tetrose, 4 carbon, pentose, 5 carbon, hexose, 6 carbon. So yung prefix sa name ng sugar, that's basically the carbon number present. Okay? So the smallest carbohydrate is a 3 carbon compound. Okay? So according to Bishop, that's glutaraldehyde. According to Rodriguez, that's glycoaldehyde. They're the same naman. Okay. Monosaccharides are simple sugars that cannot be hydrolyzed into simpler form. Kaya nga sila monosaccharides. Okay. So we have hexoses. Yung pinaka-common is glucose, fructose as well, and galactose. Two pentoses, ribose, yung isa, hindi ko nilagay, I think. Deoxyribose yata yung isa. And when we say oligosaccharides, 2 to 20 only, ito yung classification in between monosaccharide and polysaccharide. Polysaccharide naman, formed by a linkage of many monosaccharide units. Okay? Ang pinaka-common dito yung starch. Okay? Starch yung pinaka-common example natin on polysaccharide. Dextrine, products of partial hydrolysis of starch. Since when starch is being hydrolyzed, since napakahaba yung link, since napakahaba yung units niya, and then yung chain ng monosaccharide units, partial hydrolysis, dextrine, ibig sabihin hindi pa siya na further hydrolyze. So upon hydrolysis, yung kanyang hydrolyted products, mahaba pa din. Okay, so that's the dextrine. Chitin naman. Chitin, important part of exoskeleton of arthropods. Yung exoskeleton, for example, yung mga cockroach, yung shrimps, yung kanilang mga shells, that's the carbohydrate present there is chitin. Okay? Cellulose naman, this is found in plants. And fun fact lang, cellulose, I think hindi siya na-digest. That's why when you're eating green leafy vegetable, kung makikita yung sa stool ninyo, sometimes there are still big particles or big chunks of green materials because they are not digested. Okay. Glucose. The primary source of energy for human nervous system totally depends on glucose from ECF for energy. Nervous tissue cannot concentrate carbohydrate nor can it store them. Okay, if I'm not mistaken, CSF glucose it's 60% of the total glucose. Okay. Ganun kadami. Mas madaming na-render na energy ang central nervous system. Like 60 to 67%. Ganun kataas. Ganun yung percentage ng CSF glucose compared to serum or plasma glucose. Okay? Huwag niyo tatandaan. Huwag niyo kakalimutan yon. Kaya, kung napapansin ninyo, if you are stressed, if you're studying, mas mabilis kang magutom because your CNS is working. Yan. So, kaya para ongoing yung concentration ninyo when studying, you must have any food that contains high sugar content para hindi kayo mahilo or you can have any symptoms or of hypoglycemia. Okay. So this is the pathway for the pathway of glucose in metabolism. Okay. So this is the compensatory mechanism or the physiology of glucose. Okay. Focus tayo dito sa may taas. Ayan. Increased blood glucose katapos kumain or postprandial level. Katapos kumain, ano mangyayari? Normally, the glucose will increase in body fluids, especially in serum. Okay? So, the pancreas will now produce insulin. Insulin is the only hypoglycemic hormone. Okay? So, the insulin it mediates the entry of glucose into the cells. Okay? So, kung hindi nagamit yung glucose, magkakaroon ng insulin, papasok si glucose sa loob ng cell. And kapag pumasok siya sa liver, nako-convert si glucose into glycogen. And glycogen is the storage form of glucose, di ba? And when glucose will enter to fat storing cells or to the adipose tissue. Pwede din siya, storage din siya. And in metabolism of glucose naman, glucose to glycogen as storage and glycogen to glucose din. Okay? It's naman siya, reverse. Okay. So from that, magkakaroon ng equilibration. When we say equilibration, from hyperglycemia, ibig sabihin nun, yung blood glucose level above the upper limit of normal range. From all this mechanism, ma-achieve natin yung normal range of blood glucose. Okay? Huwag niyo makalimutan yun. Basta ang isipin ninyo, insulin, hypoglycemic siya kasi yung glucose sa serum or plasma, pinapapasok niya sa loob ng cells. So sa adipocytes, sa hepatocytes, sa muscle cells, ganun. Para magkaroon tayo ng normal range of blood glucose. Hindi nyo kakalimutan yun. Okay. So glucose metabolism, biochem pa din ito. By the way, if you may encounter nyo din ito sa NMAT later, kasama sa NMAT, yung mga ganitong process ng metabolism. Okay, when we have many different processes, glycolysis, gluconeogenesis, glycogenolysis, glycogenesis, lipogenesis, and lipolysis. Okay? So we have two here, the substrate and the product. When you say substrate, this is the reactants per se. And the product, yung product ng reaction. Okay? When you say glycolysis, from the words of glycolysis, this is the hydrolysis or lysis of glucose. Okay? The end product of the glycolysis is pyruvate or lactate plus adenosine triphosphate. I think 2 molecules lang yung na-produce ng ATP dito sa glycolysis. Okay? So pyruvate or lactate, they are the precursors for the Krebs cycle. Yeah. Kung naaalala niyo pa sa biology niyo kay Ma'am Kichelle, baka nasturo sa inyo to. and metabolism of glucose to lactate or pyruvate for production of energy. Ayan. And by the way, can anyone from the class tell me bakit nakalagay dito, lactate or pyruvate glycolysis? Bakit dalawa yung possible maging product? Anyone? Anyone? Lactate or pyruvate? Bakit pwedeng lactate lang? Bakit pwedeng pyruvate lang? Bakit dalawa? Bakit dalawa yung possible na maging end product? Na-discuss ba sa biotim ito? Bakit? Anyone? Bakit kaya either lactate or pyruvate? What's their difference? Wala. Sige, sa real. Kahit wala ka ng plus points, sagutin mo na lang. Yes. Yes. Okay. So lactate, napoproduce siya in anaerobic glycolysis. Yan, yung walang oxygen. Pag pyruvate, aerobic siya. Aerobic metabolism. That's why, kung mapapansin ninyo, lactic acid or lactate or yung kanyang counterpart is lactic acid. Nagkakaroon kayo ng cramps kapag nagkakaroon ng exercise. That cramping is caused by lactic acid build-up caused by anaerobic respiration. Yeah, lactic acid, lactate, tapos pyruvate. Okay? So, gluconeogenesis naman. From the word of gluconeogenesis, this is the process of production of glucose from non-carbohydrate precursors or non-carbohydrate metabolites. Kaya siya tinawag na gluconeo. Okay? Kapag nakaroon kayo ng Genesis, this is the beginning, di ba? Genesis sa Bible. Pag nakaroon kayo ng mga gen ganyan, sila yung mga precursor or sila yung start ng process. Okay? So, substrates for gluconeogenesis, amino acids, they are proteins, and lactate also. This is an organic compound to produce glucose. Ayan. Formation of glucose 6-phosphate from non-carbohydrate sources, conversion of fatty acids and amino acids to glucose by the liver. Ayan. So, madali na siyang intindihan. Glycogenolysis naman. When you say glycogenolysis, this is the hydrolysis of glycogen. For example, nagkakaroon na ng hypoglycemic episode yung isang system or yung isang human system. Nangyari, the stored glycogen or the stored form of glucose in the liver, which is glycogen, will be broken down into glucose for energy. Ito na ibig sabihin nun. Next naman, glycogenesis naman. Glycogenesis, ito yung counterpart ng glycogenolysis. This is the production of glycogen from glucose as a storage via insulin. Okay? Lipogenesis naman, lipogenesis, production of fatty acids from glucose. Ayan. That's why excessive consumption of carbohydrate will lead to weight gain dahil dito sa process ng lipogenesis. Okay? Lipolysis naman. Lipolysis, ano words of lipolysis? Okay? This is the hydrolysis of lipids or lipid precursors such as fatty acids, and the end product is ketones. Yeah. We will discuss this further in lipids kasi nagkakaroon ng ketoacidosis kapag mayroong diabetes mellitus. Okay? Later na lang yan. Or the other term for lipolysis is the decomposition of fat. Okay? Regulation of blood glucose levels tayo. Pancreas. Okay. Pancreas is the major organ in the body that controls our glucose levels. Okay? Functions as both an endocrine and exocrine organ in the control of carbohydrate metabolism. Okay? When we say endocrine gland, this is signals from hypothalamus. And exocrine gland naman, they are these products are excreted out. These products are excreted from the organ itself. Okay, so as an exocrine gland, it produces and secretes amylase. Yan. Ano pa yung ano pa yung isang organ or yung isang gland that produces amylase aside from the pancreas? Anyone? Anyone from the class except Cyril? Ano pa yung isang organ?
Saliva, sir.
What?
Saliva po.
Yes, salivary gland. Ayan, salivary gland. Since the salivary gland, it is an exocrine gland kasi it produces saliva. Parang ganun din yung mechanism ng pancreas sa labas. Kasi kapag ganun si endocrine gland or endocrine system, sa loob ng circulation nangyayari yung signals ng hormones. Okay? So amylase, this is both secreted by pancreas and the salivary gland, okay, for the production of carbohydrates, mga polysaccharides. Okay? That's why amylase is used also as a pancreatic marker. Kapag merong cancer ang pancreas, amylase is also a pancreatic marker kung merong tumor growth doon sa mga salivary glands. Okay? Huwag niyo kakalimutan yan. As an endocrine gland, it secretes the hormone insulin, glucagon, and somatostatin. Okay? Endocrine sila. Sa circulation ng nangyayari yung signal. Lahat, di ba sinabi ko sa inyo dati, lahat ng hormones that is related to carbohydrate metabolism are hyperglycemic except insulin, kasi insulin is the only hypoglycemic hormone. Okay? So somatostatin, glucagon, they are hyperglycemic. Later on, somatostatin kasi ano siya, more like yung discuss siya sa hormones na mismo sa CC2. Okay? Sa may part ng IGF and gigantism later. Insulin. What's the mass of insulin? 5,000 daltons. It is an amino acid. It is a protein with 21 amino acid alpha chains and 30 amino acid beta chains. Kung nyo kakalimutan to, lumalabas sila sa comprehensives. 21-30. Okay? Produced by the beta cells of the islet of Langerhans as proinsulin. Take note. Insulin is not produced as the complex or fully mature insulin. Meron siyang precursor which is the proinsulin. Nagkakaroon mo na ng proinsulin and then insulin. Ayan. Nakakalito siya. Kapag tinanong sa inyo, ano yung nire-release ng beta cells? Ano yung nire-release ng beta cells abruptly? Ano yung unang nire-release ng beta cells? Insulin or proinsulin? Usually proinsulin yung sagot doon kasi ito yung precursor ng insulin. The primary hormone for the entry of glucose into the cell. Kaya nga siya, hypoglycemic. It lowers the levels of glucose in the serum. Kaya nga pinapapasok niya ang glucose sa loob ng cell. Ano lang ibig sabihin niya? C-peptide. Ratio of C-peptide to insulin is 5:1 to 15:1. Ayan. So, paano nagkakaroon ng C-peptide? C-peptide is produced from the production of insulin. So, carbopeptidase H, the insulin secretory granule, leads to secretion of proinsulin. So, upon production of insulin, nagkakaroon ng C-peptide production. Okay, huwag niyo kakalimutan yun. And the ratio, 5:1 to 15:1. Okay? Mas madami yung C-peptide compared kay insulin. 5, for example, 5 ng C-peptide, diba ng insulin, huwag niyo kakalimutan. What elevated proinsulin? What are the instances kapag tumataas ang proinsulin levels? Type 2 diabetes or the adult onset diabetes, pre-type 1 diabetes, or the familial, hyperinsulinoma. Ano ba kasi nangyayari kapag meron kang hyperinsulinoma or the pancreas secretes abnormally large amount of insulin. Pwedeng tumor sa pancreas, pwedeng tumor sa pituitary gland or sa hypothalamus. Nakadepende yan sa kung ano level. Pwedeng secondary yung hyperinsulinoma. It is caused by the pituitary gland. And familial hyperinsulinemia. Familial hyperinsulinemia, genetic siya. Hereditary hyperinsulinemia. Sabihin nun, the pancreas is producing very high levels of insulin kaya nagkakaroon ng hypoglycemic episode. Kapag ganito yung nangyari sa isang patient, meron siyang hyperinsulinemia, lagi siyang walang energy kasi kahit kailangan kailangan ng kanyang body ang glucose, pinapapasok ng insulin ang glucose sa cells kasi nga meron siyang excessive amount of insulin. Kaya, in other term, agkakapsot kanayon. Okay? Ganun yung ibig sabihin. Glucagon. Primary hormone responsible for increased plasma glucose levels. Primary hormone. This is the primary hyperglycemic hormone, see, glucagon. It is an hyperglycemic agent. Okay? It is characterized by alpha cells of islets of Langerhans in the pancreas or the Langerhans cells of distal small bowel. Doon nakikita. Okay? It is released during stress and fasting states. Okay, glucagon, doon sa fight or flight situation, lumalabas si glucagon. Stress. Okay? Doon sa fight and flight response ng CNS sa ANS, lumalabas si glucagon. Kapag naman rest and digest ng CNS, doon nagkakaroon ng maximum effect si insulin. Okay? And fasting state. Siyempre, fasting state, hypoglycemic ka na dyan. So, the glucagon will signal the hepatocyte to release glucose from the glycogen. Ano lang? It's a system, hindi nyo kakalimutan. It enhances catabolic functions during fasting periods. It promotes glycogenolysis. Ayan, dito pala siya. It promotes glycogenolysis. Tinawag siyang catabolic function because glycogenolysis from glycogen to glucose. That's why it's a catabolic process or catabolism. Okay? Huwag niyo kakalimutan. Somatostatin inhibits both insulin and glucagon secretion of other hormones synthesized by the delta cells of the islets of Langerhans, which comprises 5 to 10% of the islet cells. Ayan. Okay? Some books, somatotropin. Sorry, mali na sabi ko kanina. Somatotropin pala yun. Sorry. Somatotropin pala yung hyperglycemic. Hindi siya somatostatin. Sorry na pag-mix up ko lang. Somatostatin inhibits pala to. Inhibitory ba ito somatostatin? Paano natin malalaman na inhibitory siya? From the yung kanyang suffix. Suffix ba? Tawag na. Somatostatin. Tatin. Yung in niya, inhibitory hormone siya. Okay? Inhibitory hormone si somatostatin. Yung kanya palang counterpart is si somatotropin. Sorry. Okay? So it inhibits both insulin and glucagon secretion of other hormones. It is synthesized by the delta cells of the islet of Langerhans, which comprises 5-10% of the islet cells. Take note niyo yan, 5-10% of the islet cells for the somatostatin. Okay? Okay. Other hormones that tend to increase glucose concentration. Okay. Kung napapansin ninyo, most of the hormones here are stress hormones like cortisol, catecholamines, adrenocorticotropic hormone. They are all stress hormone. Growth hormone as well. Kaya ako sinabi sa inyo kanina, okay? Yung somatotropin. Somatotropin, yes. Part siya na partly growth hormone. Okay? Thyroid hormone as well. Okay. So cortisol and corticosteroid secreted by the cells of the zona fasciculata and zona reticularis. decreased intestinal entry of glucose into cells. It promotes glyconeogenesis and lipolysis. Okay, take note nyo yan. You will discuss it further in renal function sa AUBF, yung mga layers ng kidney, zona fasciculata, zona reticularis, may isa pang ZFR. Glomerulari siya din isa. And catecholamines, it is released from the chromaffin cells of the adrenal medulla. Chromaffin. Kapag narinig yung chromaffin cells, they are catecholamines. Okay, catecholamines. Chromaffin cells, catecholamines, it inhibits insulin secretion and promotes glycogenolysis and lipolysis. Okay. Growth hormone, secreted by the anterior pituitary gland, decreases entry of glucose into cell. It promotes glycogenolysis and glycolysis. Ayan. Kaya kung ano mapansinin nyo, during puberty, most of the sa male, especially sa male, most of the cases, pumapayat ang mga male during puberty kasi nag-elongate yung bone in response to growth hormone. And growth hormone is a hyperglycemic hormone. Ayan. Kaya nababawasan ang adipose tissue mass dahil niya hyperglycemic ang growth hormone. Ayan. Kaya huwag niyo makalimutan yun. Hormone. When you say thyroid hormone, they are responsible for metabolism. Kaya we have the term hyperthyroidism and hypothyroidism. Kapag yung isang patient meron siyang hyperthyroidism, payat yung isang patient. Kahit siya ng kain, mabilis yung kanyang metabolism, mabilis yung kanyang digestion, hindi siya tumataba. Kaya kasi nga, thyroid hormone is a hyperglycemic hormone. Huwag niyo kakalimutan yun. So we have three major thyroid hormone, the T3 and the T4. The T3 or the triiodothyronine, and the T4, tetraiodothyronine or the thyroxine. Okay. Secreted in the thyroid gland. It promotes glycogenolysis, gluconeogenesis, and intestinal absorption of glucose. Yeah. Next naman, adrenocorticotropic hormone. It stimulates release of cortisol from the adrenal cortex. Ano siya? Tropic hormone siya. Usually kapag tropic hormone, this hormone is located in the pituitary. Okay? Okay. It stimulates the release of cortisol from the adrenal cortex. Kasi guys, ano nangyayari? I don't know if you've already encountered this in your physiology. Kapag tropic hormone, it will signal the organ. So, adrenocorticotropic hormone, isa-signal niya yung kidney to produce cortisol. Ganon. So, tatlong level. So you can now categorize the disease if it's primary or secondary or tertiary based on the organ or hormone na tumatakas. For example, tinawag siyang secondary hypercortisolemia kapag yung problem na sa pituitary. Tinatawag siyang primary hypercortisolemia kapag yung problem na sa hypothalamus. Tinatawag siyang tertiary hypercortisolemia kapag yung problem na sa kidney. So, basta yung kanilang main hormone or analyte na produce is on the organ. Ayan. Dito na lang yan sa inyong CC2. Okay? CC2. It promotes glycogenolysis and gluconeogenesis. So, the general observation, yung kanilang mechanism of action is they are part of catabolism to stimulate production of glucose. Yeah. Clinical conditions of carbohydrate metabolism. Hypoglycemia. Limited hypoglycemia, from the word itself, hypo, yung kanyang prefix, hypo ibig sabihin low. nasa lower limit ng normal yung levels ng glucose in serum or plasma. Okay? So glucagon and other hyperglycemic factors are released between 65 to 70 milligrams per deciliter. Ayan. Kung umabot na ng ganyang levels, yung blood glucose, magre-release na yung mga organs, especially liver, kidney, pituitary, ng mga hormones to stimulate production of hyperglycemic agents like glucagon, cortisol, mga ganon. Mga hyperglycemic hormones. Kasi nga, mababa na yung level. Okay? Ito yung compensatory mechanism ng hypoglycemia. Okay? Characterized by low plasma glucose, usually an overnight plasma glucose of less than 45 milligrams per deciliter, and an associated groups of symptoms that are relieved by ingestion of water, of food, or carbohydrates. Okay. So nagkakaroon ng hypoglycemia kapag if the overnight plasma glucose is this level, kapag less than 45, lalabas na dyan yung symptoms. Okay? Kapag 45, lalabas na dyan yung symptoms. Tinatanong ito sa board exam, guys. Kailangan tandaan. At what level of glucose lalabas ang symptoms ng hypoglycemia? Less than 45. Okay? Less than 45. Kapag nahihilo na, ganyan, nahihilo, ganyan. And then, kapag pinakain mo naman na, kapag pinakain mo, nawawala yung pagkahilo niya, that's basically hypoglycemia lang yun. Hindi na siya any other related disease. Okay? Hypoglycemia na siya. 50 to 55 milligrams per deciliter, observable symptoms. Observable. Kapag less than 45, tapos observable, din yung sasagot ninyo. Kapag lumabas si 50 tapos 55. Kasi kapag 45 na siya, symptoms na talaga siya. Okay? Kapag 50 to 55, ito yung parang window ng symptoms. Nakakaramdam na ng konting paghihilo, ganyan. Pero kapag kapag less than 45, dyan na parang hindi ka na makagalaw. Come on, yung ibig niya sabihin. Okay? Huwag niyo kakalimutan ito. Basta kapag nabanggit, observable symptoms, 50 to 55. Kapag 45, less than 45, tapos pinakain, tapos nawala yung symptoms. Basically, hypoglycemia in overfasting state. Okay? Overfasting ba? In overnight plasma glucose. Huwag niyo kakalimutan. Okay? Can occur when there are appropriately elevated levels of insulin or inadequate glucose production. Saan ito nangyayari? Nagkakaroon ng super low levels of glucose when you have, yung nabanggit ko kanina, familial hyperinsulinemia. Kapag meron kang familia, yung tumor, forgot, tingnan natin. Ano ba yan? Saan na? Hyperinsulinoma. Sorry. Ito pala, ba't hindi ko ito na-discuss? Ulitin ko na to. Hindi ko ito na-discuss ha. Okay. So, yeah. Insulin level C-peptide. Okay, ito. Dito tayo. How will you differentiate if the patient has an pancreatic tumor or insulinoma, or the patient has type 1 diabetes mellitus, or it has absence of insulin? Okay. So, insulin levels increase. When type 1 diabetes, syempre wala siyang insulin, kaya nagkaroon siya ng diabetes. Absolute negative. Okay? For C-peptide, ano ba yung relationship ng insulin C-peptide? Lagi sila magkasama. Kapag mataas si insulin, mataas si C-peptide kapag physiologically produce insulin. Okay. Kapag naman insulin treatment, kapag sasaksakan mo ng insulin yung patient, ano mangyayari sa insulin level niya? Tataas. C-peptide, tataas din ba? Hindi siya tataas. Kasi, hindi naman na-produce si insulin physiologically. C-peptide is produced upon physiological production of insulin. Kaya kapag insulin treatment yan, insulin lang yun, hindi tataas si peptide mo. Unlike physiologically or physiopathologically induced insulin production, tataas si C-peptide. Okay? For type 1 DM naman, absolute negative, decrease CC-peptide. Take note guys, decrease, hindi absent, hindi siya absent. Kasi there are some references or some books na nagsasabi na parang the body is trying to compensate the loss of insulin. Kaya parang tinatry ng pancreas mag-produce ng insulin pero hindi siya nakaka-produce. Ang napoproduce lang yung kanyang ano ba yung term kasi peptide? Yung kanyang secretory granule yung napoproduce. Kaya parang meron pa din si peptide sa type 1DM pero sobrang konti lang. Okay? Huwag niyo kakalimutan yun. Okay. Can occur, tapos na pala yan. Hyperinsulinoma. Hyperinsulinoma. Tapos yung isa, kanina. The warning signs and symptoms of hypoglycemia are related to central nervous system. Ano ba yung sinabi ko sa inyo kanina? Almost 60 to 67%, basta around 60% ng serum glucose ng total system glucose ay nasa CNS. Kaya kung mababa ang glucose nyo, ang unang mararamdaman is panghihilo. Yun yung unang mararamdaman. Kasi yung CNS related ang symptom. Neuroglycopenia. Take note, neuroglycopenia. CNS disorder resulting hypoglycemia. So hindi siya related sa food intake, hindi siya related sa pancreatic disorder or sa familial diseases. It is just that this type of disease can result to major signs of symptoms of hypoglycemia dahil meron kang CNS disorder. Ayan. Naghanap kami dati na kung ano yung symptoms. Pwedeng tumor-induced hypoglycemia in the CNS. Pwedeng sa lining ng vertebra, pwede doon sa may choroid plexuses na nagpo-produce ng CSF, pwede magkaroon ng tumor doon, or pwede magkaroon ng blockade doon sa may circulation ng CSF sa CNS. Kaya nagkaroon ng neuroglycopenia. Okay? Postpartum infant who are fed showing blood glucose level less than 40 milligrams per deciliter are usually treated by pediatrician and follow-up evaluation to identify cause of hypoglycemia. Okay. So these are management naman sa mga postpartum infants. Kapag sabi dito, kapag sobrang baba ng level nung blood sugar levels ng infant, and then papakainin, the pediatrician will rule out kung ano yung source ng hypoglycemia. Pwede bang the pediatrician can differentiate kung kulang lang ba siya sa food intake or pwedeng symptoms or signs na siya ng inborn error of metabolism. So, yan lang. Basta take note nyo yun. 40 milligrams per deciliter. Okay? I-recap lang natin yung mga values dito sa hypoglycemia. 65 to 70. Kapag ganyan yung level, nagkakaroon na ng catabolism. Pag 65 to 70, tumataas si glucagon, yung ibang factor. Kapag naman less than 45 milligrams per deciliter in overnight, kapag naman less than 45, tapos pinakain, that's hypoglycemia. 50 to 55, observable or window ng symptoms kapag umabot ng 50. Yan. Kapag naman 40 milligrams per deciliter, sa infant ito nakikita. Okay? Huwag niyo kakalimutan. Classification of hypoglycemia according to Rabor. Okay. So according to Rabor, parang kulang. Hindi, parang yan lang talaga siya. Pero may kasama yan, hindi ko na lang sinali. ito yung pinaka-importante nakita ko. Classification of hypoglycemia according to Rabor. Patient appears healthy. The patient appears healthy, hindi naman ganun kapayat, hindi naman ganun ka-overweight. Yan. Nagkakaroon ng hypoglycemia in cases of drugs. Alcohol. Di ba sabi ko sa inyo dati, alcohol, it is an hypoglycemic agent. Kaya nakakagutom kapag may hangover. Salicylates. These are drugs. These are drugs for, mga antipyretic drugs and haloperidol. Yeah. Insulinoma. Overproduction of insulin, kaya nagkakaroon ng low blood glucose level. Islet hyperplasia or nesidioblastosis. Islet hyperplasia. Ano ibig sabihin ng hyperplasia or hyperplastic yung isang organ? Madaming cells yung isang organ, nagkaroon ng hyperplasia kaya. Since madami yung cells sa isang organ, madami din yung kanilang nasa-secrete. Kaya, dadami ang insulin. Persistent hyperinsulinemic hypoglycemia of infants. Ito kanina, ito yung parang satellite description ng 40 milligrams per deciliter para i-rule out ng physician if it's hypoglycemia or an inborn error of metabolism. Ayan. Take note nyo ha, persistent hyperinsulinemic hypoglycemia of infants. Okay? Non-insulinoma pancreatogenous hypoglycemia syndrome. When you say syndrome, ano yung sabihin ng syndrome? This is a mixture of symptoms. Okay? Non-insulinoma pancreatogenous hypoglycemia. Paano yan malalaman? Ibig sabihin nun, non-insulinoma, walang tumor. But the hypoglycemia is located in the pancreas. Kaya nga siya tinawag na pancreatogenous. Genus. Di ba sabi sa inyo dali kapag nakarinig ng mga gen? Doon yung parang doon ng galing, doon yung start. Okay? Pancreatogenous hypoglycemia syndrome. Okay? Familial hypoglycemia, severe exercise. Severe exercise, ano nangyayari? Anaerobic respiration. Okay? Magkakaroon kayo ng glycolysis. Abrupt or elevated rate of glycolysis, magkakaroon ka ng hypoglycemia. Ketotic hypoglycemia. Saan ito nangyayari? Sa mga hindi kumakain. Nangyayari sa mga hindi kumakain. Ketotic hypoglycemia. Okay? From ano dito? Parang nagkakaroon na kayo dito ng gluconeogenesis. Tumataas ang ketone bodies or keto acids sa serum and urine. Okay, hindi nakakalimutan. Compensated coexistent disease. Drugs. Disopyrimidine, beta-adrenergic blocking agents. Sulfhydryl or thiol-containing drugs, unripe ackee fruit, and undernutrition. Search nyo itong unripe ackee fruit. Parang reddish na merong white na pulp or white na fruit na merong red na pulp. Basta white and red yung color ng ackee fruit. Okay? Yung ackee fruit na yan, it causes severe hypoglycemia. That's why some researches and some pharmacy industry, they are using this type of fruit to formulate drugs to lower blood glucose levels in DM patients. Unripe ackee fruit and undernutrition. Okay. Take note nyo yung mga drugs, mga thiol-containing drugs. Ito nakita, sulfhydryl or thiol-containing drugs. Nakita yan sa antibiotics. Okay. Disopyrimidine and beta-adrenergic agents as well. Patients appear ill. Hypoglycemia pa rin ito ha. Patients appear ill. Okay, drugs. Pentamidine and pneumocystis carinii pneumonia or pneumocystis jirovecii pneumonia. This is a parasitic parasite-induced pneumonia ng ispis po. parasite-induced pneumonia siya. Okay? And pneumocystis carinii pneumonia. Isa yan sa pinaka-notable description ng P. carinii or P. gyruvesi pneumonia. By the way, P. gyruvesi is I think it's the new term. Yes, it's the new term. Hindi na P. carinii. Pero same lang sila. Okay? Kapag nabanggit sa inyo sa parasitology later, na P. carinii or P. gyruvesi hypoglycemia, aside from respiratory symptoms. Okay? Okay. Sulfamethoxazole and trimethoprim and renal failure. SXT. Itong sulfamethoxazole and trimethoprim. SXT. Also, kung napansin niyo, sulfa drugs din ito. Antibiotic din siya. Okay? And renal failure. Okay? Renal failure. Okay. Bakit kayo renal failure? Any idea? Renal failure and hypoglycemia, bakit kaya nangyari? Any idea? Kasi, di ba kapag renal failure, sira yung glomerulus. Kapag sirang glomerulus, ano mangyayari? Hindi na ma-filter yung glucose. Okay? Kaya yung ultrafiltrate, lalabas lahat ng glucose from the serum or plasma. From the plasma. Okay? So lalabas lahat ng glucose. Kung may matitira pa bang glucose sa plasma, konti na lang. Kaya ng hypoglycemia. Renal failure. Okay? Profoxin and renal failure. Again, profoxin. Quinine and cerebral malaria. Okay? Quinine is a drug for malaria. I think pentamidine is a drug also for P. carinii. Okay? For P. carinii. Ayan. Okay? Quinine and cerebral malaria. Topical salicylates and renal failure. Salicylates again, kanina din, mga antipyretic drugs. Okay? Types of hypoglycemia. Guys, wait lang. Water break. Sila na lang muna. Okay, let's assume. Okay, wait lang. We have two types of hypoglycemia. We have two types of hypoglycemia: the fasting or the post-absorptive, and the postprandial, alimentary or reactive hypoglycemia. Okay. When we say fasting, syempre, common sense, kapag nag-fasting ka, mababa ang blood sugar level. Okay? Occurs after 10 hours without food, or MPO, or non-per-orem. Okay? Secondary to hyperinsulinism or insulinoma. Okay. Insulinoma, this is the term for the tumor, and the effect of insulinoma is hyperinsulinism. Okay? Hormonal deficiency, genetic parang kulang ito. Genetic factors, autoimmunity, or drug induced. Ayan. Okay. So isa-isahin natin ha. Hyperinsulinism, pag mataas ang insulin, pag madaming insulin, mababa ang glucose. Hormonal deficiency. Okay. Hormonal deficiency, parang partly, parang, tawag dito, hormonal deficiency, partly dito sa may insulin, okay, pero hindi insulin yung mababa. Okay? Genetic factors, type 1 diabetes mellitus, hindi siya type. Genetic factors, familial din, familial hyperinsulinoma. Autoimmunity, this is very important. When we say autoimmunity, the body is producing antibodies against some of the major hormones that controls hyperglycemic episodes. For example, meron kang antibody on the cells that secretes glucagon. Magkakaroon ka ba ng glucagon? Kung sinisira ng antibody yung cells that secretes glucagon, konti lang or pwedeng wala. That's called autoimmunity. Okay? Or drug-induced. Ang dami nang nabanggit kanina, mga antipyretics, antibiotics, mga ganun. Okay? Mga antiparasitics, ganun. Postprandial, alimentary, or reactive naman. Occurs usually within 4 hours after eating a meal. Kaya siya tinawag na postprandial and alimentary or reactive. Naubos na yung glucose or yung glucose reserves in the plasma. Okay? Alimentary, pag sinabi alimentary tract sa digestive system. Tapos ko nga, ibig sabihin nun, the digestive system or the alimentary tract, wala na siyang na-absorb na glucose from food intake. Ganyan. Kaya nagkakaroon ng postprandial. Okay? This is usually not serious. Nagkaroon ka ng postprandial hypoglycemia. Ano yung symptom? Kapag nagkaroon ka ng postprandial hypoglycemia, the most common symptom, anyone from the class? Ano yung una niyo mapapansin kapag meron kayong postprandial hypoglycemia? Anyone? Ano yung una yung napapansin? What's the first symptom?
Hunger, sir.
Pardon?
Hunger.
Hunger. Tama. Yumol. Hunger. Okay? Kaya 4 hours siya. Kaya, di ba, for example, kumain kayo ng 8 a.m. or 7:30, pag 12 na parang without seeing the clock. Pero pag parang feel mo ng gutom ka na, pag tingin mo ng orasan, alas 12 na pala. Okay. Kasi 4 hours yan. Ano yung kakalimutan? Hunger stimulates food intake due to postprandial hypoglycemia. Okay, makalimutan nyo. Okay. Whipple's triad of hypoglycemia. This triad is used to diagnose hypoglycemia. Okay? Kung meron tayong tatlo, ibig sabihin nun, mababa lang ang blood glucose level. Symptoms. of hypoglycemia. Nahihilo ka, hindi ka makafocus. Okay? Nahihilo, nagugutom. That's the symptoms of those are few of the symptoms of hypoglycemia. Low plasma glucose levels, umabot ng 75 milligrams per deciliter. Relief of symptoms with correction of hypoglycemia. Ito kanina yung less than 45. Kapag kumain ka tapos hindi ka na nahilo, hypoglycemia lang yun. That's why we have this Whipple's triad. Whipple's triad of hypoglycemia. Itong tatlo. Symptoms, yung glucose level, and then the relief of symptoms upon food intake. Okay, that's the Whipple's triad. Yung kakalimutan. Insulinoma or islet cell hyperplasia. Tumor. Okay? Kapag nakakita kayo ng OMA na suffix, it is tumor. Okay? Like hematoma, insulinoma. Kapag sinabing tumor, parang kapag kasi sinabing tumor, part siya ng inflammation, tapos parang dito, swelling. Swelling. Kapag may OMA, swelling. Okay, insulinoma, swelling, kasi nga islet cell hyperplasia, madami yung cell, lumalaki yung isang organ, or lumalaki yung isang tissue. Okay, insulinoma. Kaya kung napapansin niyo sa mga face-to-face, kapag meron kayong hematoma, matigas yung area kasi nagkaroon ng swelling. Okay? And na-discuss na ito sa sa histopath. What are the major signs of inflammation? Diba? Redness, swelling, pain, and loss of function like dolor, calor, tumor. Basta yung mga signs ng inflammation. OMA. Okay? Kapag sinabing OMA, may swelling. Seen in individual who secrete insulin excessively due to tumor. Okay? Hyperplasia. Dumadami yung cell. Ibig sabihin kapag dumadami yung cell, metastatic yung cell. Okay? Kaya nagkakaroon ng swelling. Lumalaki. Okay? Usually seen and without coexistent disease or ingestion of hypoglycemic drug. Ayan. So parang at first, kung i-access ito ng physician, mukha naman siyang healthy. Wala namang sorry, lost yung connection. Okay. So, dito sa insulinoma, yung presentation ng signs and symptoms, parang idiopathic siya. Kumakain yung patient, hindi naman siya nag-take ng hypoglycemic drugs, pero meron pa rin siyang hypoglycemia. So basically, parang isipin ng physician, baka merong derangement doon sa kanyang pancreas. Okay? Kaya, in order to diagnose insulinoma, madaming ways. Una, pwedeng biopsy. Pero parang ano siya, parang biopsy of pancreatic tissue is the definitive yata kapag biopsy ang insulinoma. The diagnostic 72-hour prolonged supervised fast is usually used. 3 days prolonged supervised fasting. Ito yung diagnostic na ginagawa. Okay? At first, pero hindi na ito ginagawa ngayon, itong 72-hour prolonged supervised fast. Okay? Madami naman ng modalities to diagnose insulinoma, mga X-ray, yung mga imaging, biopsy. Kasi napaka-cruel naman na 32 hours supervised fast yung ginagawa. And by the way pala, itong source na to, kay Tabor ito. And si Tabor is a matanda ng source. Pero very helpful siya to understand hypoglycemia kasi kay Inma ko. Okay? Ito. Hyperglycemia naman tayo. Hyperglycemia, this is the term used when the blood glucose level is above the upper limit of normal. Okay? An increase in blood glucose level, what are the causes? Stress. Nabanggit ko kanina, pag may stress, tumataas yung mga hyperglycemic hormones. Severe infection, dehydration or pregnancy, pancreatectomy, hemochromatosis, insulin deficiency, abnormal insulin receptor. Ayan. Isa-isahin natin. Okay. Severe infection. Nagkakaroon ng hyperglycemia in severe infection. This is due to glucagon secretion. Okay, severe infection na yan. Dehydration or pregnancy. This type of hyperglycemia is relative. This is relative hyperglycemia kasi normal naman yung normal naman dapat yung kanyang blood glucose level dehydrated lang. So, yung kanyang plasma or serum is saturated. Kulang yung solute, kulang yung water. Kaya relative hyperglycemia. Okay? Pancreatectomy. Natanggal ang pancreas mo. Mag-produce ka pa ba ng insulin? Hindi na. Okay? Hemochromatosis. Okay? Kapag masyadong hemochromatosis is an RBC abnormality, either in the bone marrow. Kapag nagkaroon ng hemochromatosis, magkaroon ng hyperglycemia. Okay? Parang satellite symptom ng hemochromatosis, mataas ang iron levels. Okay? Insulin deficiency, syempre, obviously, kung wala kang insulin, magkaroon ka ng hyperglycemia. Saan nakikita? Sa type 2 diabetes mellitus or adult onset diabetes mellitus. Okay? Abnormal insulin receptor. Okay. Since our hormones, they are like yung insulin para pumasok yung glucose sa loob ng cell, the insulin will have a specific receptor to mediate the transport of glucose from the outside to the inside of the cell. Kapag abnormal yung insulin receptor mo, papasok ba si insulin together with glucose? Hindi papasok. Kaya, if we have this type of case, kapag mayroong abnormal insulin receptor, tataas kasi hindi papasok yung glucose sa loob ng cell together with insulin. Okay? FBS level, 126 milligrams per deciliter above, that is also considered hyperglycemia. Di ba guys, 126, nasa range pa rin siya ng FBS, mga 90 to 126. Yeah. 110 to 126. That's the fasting blood sugar. Kapag si patient, fasting specimen, yung kanyang FBS is 140. That is one marker or one parameter for the diagnosis of diabetes mellitus. Okay, ano yung ibig sabihin? Kaya nandito lang dapat. Kapag lang FBS kayo, tapos nasa around 130 to 140, medyo warning sign na yun or meron na kayong diabetes mellitus. All adults older than 45 years old should have measurement of fasting blood sugar every 3 years unless the individual is diabetic. Take note, all adults older than 45 years old should have measurement of FBS every 3 years. Parang 3-year check-up on FBS kahit wala kang nararamdaman. Para makita mo lang if your glucose metabolism or your pancreas is still working. Okay, ganun yung ibig sabihin. Kasi guys, itong age group na to, 45 and older, they are very prone to type 2 diabetes mellitus. Ito yung mga adult onset diabetes mellitus. Mataas yung risk kapag ganyan yung age group. Okay? Kaya every 3 years dapat nagpaka-FBS. Unless the individual is diabetic. Kapag diabetic yan, more frequent ang FBS. Wala namang frequency, basta more frequent kapag diabetic. Siyempre, if you're diabetic, you must know your blood sugar level more frequently para malaman mo kung in control yung yung treatment or gumagana yung treatment plan. Okay? What are the laboratory findings in hyperglycemia? Siyempre, commonly, increased glucose in plasma in. Ano ulit yung renal threshold ng Anyone from the class, what's the renal threshold for glucose? Above that renal threshold, makaka-detect ka na ng glucose sa urine. What's the renal threshold? Anyone?
Sa glucose, sir? 160
Sa urine.
to 180. 180 po.
Ano ulit code mo, Marilu?
5139, sir.
5.3. Okay. So that's it. Okay, 160 to 180. Ano ba kasi ibig sabihin ng plasma ay ng renal threshold? For example, si isang patient, yung kanyang plasma glucose level is 150. Makakakita ka ba ng urine? Makakakita ka ba ng glucose sa urine? Hindi. Pero pag si patient na diabetic, yung kanyang glucose level is 200 milligrams per deciliter. Dan ang glucose sa urine? Yes. Because normally, walang glucose sa urine. And take note, the renal threshold is very high, 160 to 180. A normal person, aabot man siya pero hindi ganoon ka-common na umabot ng 180 ang plasma glucose. Kasi kapag nagpapa-RBS or FBS yung mga patient natin, nasa around 140, 130, 110, 90, ganun lang. And take note nyo, sobrang taas ng renal threshold, 180 or 160 to 180. And ang mga diabetic patient, it's very common na umabot ng 200 plus yung kanilang mga random blood sugar. Okay? Kaya, nagkakaroon ng glucosuria, yung isang diabetes, yung isang DM patient. Okay? Take note nyo. Increase urine specific gravity. Okay. Very din. Since madaming solute yung urine, which is comprised primarily of glucose, from overloading or plasma overloading ng glucose, syempre tataas ang specific gravity. Ketones in serum and urine. Okay. Parang wala akong dito nalagay na diabetes mellitus. Nasaan module? Okay. Ganito kasi nangyayari dyan. Okay, so the patient has a diabetes mellitus. Okay. Wala siyang insulin. Since wala siyang insulin, ang mangyayari, hindi makakapasok yung glucose sa loob ng cell. So, basically, the body will tell na walang energy. Because in order to have an energy, dapat meron kang glucose sa loob ng cell for cellular respiration. Since hindi makakapasok ang glucose sa cell because of insulin deficiency or insulin insufficiency, mangyayari, the body will compensate the loss of energy via gluconeogenesis. So the body will now produce glucose for energy by non-carbohydrate sources like fatty acids and amino acids. Ayan. Ano ulit yung byproduct ng lipolysis? Ketones. Accelerated lipolysis. Tataas ang ketones or ketone bodies. Yan. Tataas ang ketone bodies kaya nagkakaroon ng ketosis. Nagkakaroon ng metabolic acidosis. Kapag mataas ang ketones sa serum and urine because hindi nagagamit yung glucose or hindi natatolerate yung glucose. Okay? So, ganun nangyayari. That's why ketonuria and glucosuria is the paired symptoms of diabetes mellitus in urinalysis. Laging magkasama. Kapag mataas si glucose, most likely mataas si ketone. Ganun lang yung ibig sabihin nun. Okay? Kapag naman mag-glucose pero walang ketone sa urine, pwedeng postural hyperglycemia, pwedeng excessive exercise, ganun lang. Pero pag naging combo, mataas si ketone, mataas si glucose, most likely the patient is diabetic. Okay, ganun lang ibig sabihin nun. Hindi kasi na-utilize ng body yung glucose kapag diabetic ka. Kaya the body will compensate by producing energy from non-carbohydrate sources. But the risk of acidosis is very high. Okay? Ganun lang yung ibig sabihin nun. Okay. Decreased blood and urine pH, that is due to ketosis. Since ketone bodies are ketoacids, kapag sobrang taas ng ketones, syempre mababa ang pH because of ketoacidosis. Ganun lang ibig sabihin nun. Electrolyte imbalance, low sodium, high potassium, low carbonate. Okay, ito. So nagkaroon ka ng electrolyte imbalance. Okay. Low sodium, potassium. Okay. Piso. Yung mnemonics natin na piso, potassium in, sodium out. In glucose metabolism, i-discuss nyo ito further sa lecture ninyo that upon entry of glucose into the cell, parang imimediate ng potassium, glucose, and insulin. So parang potassium, glucose, insulin, sama-sama silang papasok sa loob ng cell. Ayan. Kapag hindi makapasok si glucose sa cell, si potassium, papasok din ba? Hindi. Ayan. So magkakaroon ng electrolyte imbalance. Kasi yung normal is si potassium dapat nasa loob siya. Si sodium nasa labas. Okay. Kapag nagkaroon ng insulin deficiency, karoon ng diabetic mellitus, automatic magkakaroon ka ng electrolyte imbalance. So delikado 'yan. Kaya yung sequelae ng kaya yung mga symptoms ng diabetic, pwede kang magka-heart attack kasi nga mataas ang potassium, hyperkalemia. Yan, pwede kang magkaroon ng any cardiovascular disease, magkakaroon ka ng stroke, magkakaroon ng ketosis, yan, magkakaroon kayo ng hyperketodiabetic coma, magkakaroon ng amputation. So basically, pag meron kang metabolic disorder like diabetes mellitus, affected lahat. Okay? So ganun yung nangyayari. Okay? So ganun siya. Okay, yun lang. Yun lang dito sa slide. Pero parang kulang. Yung diabetes mellitus, hindi ko nalagay. Hindi, parang okay. Nasa module naman siya. Nandoon yung difference ng diabetes mellitus. Okay. Wait lang. Tignan ko lang dito kung naano ko siya, kung nailagay ko sa module. Okay. Carbohydrates part 2. Meron palang part 2. Hindi ko nagawa ng PowerPoint. Sorry. Okay. So far, naiintindihan nyo naman yung pathophysiology ng diabetes mellitus kasi dapat maintindihan ninyo para hindi na kayo memorize. Andito pala, hindi ko nalagay, Lord. Andito, wala siyang PowerPoint. Wait lang, nasaan yun? Carbohydrates. I-share ko na lang ito. Ano ba yan? Wait lang. Okay. Akala ko 26 slides lang. Okay, sige. Maraming salang lecture na to. Okay, nakikita? Nakikita? Okay. So this is the part 2. Dalawa pa rin module dito sa diabetes. Sorry. Okay. Diabetes mellitus, a genetic disorder of glucose metabolism that results in insulin deficiency and lack of carbohydrate tolerance. Take note, lack of carbohydrate tolerance. Ibig sabihin nun, hindi nila natotolerate or hindi nila nagagamit yung glucose. Okay? Kaya meron silang tolerance. They cannot tolerate or they cannot use glucose. Okay? It is a metabolic disease characterized by hyperglycemia. HLA, DR4, DR3. In your serology, diabetes mellitus, namamana siya. Namamana ang diabetes mellitus kasi it is linked on the HLA antigen. Basta ano yung data sa serology ninyo yan, sa IS nyo. Okay? FBS is greater than or equal to 126 or on more than one testing are diagnostic. Ano ibig sabihin yan? For example, nagpa-check up ka sa physician, pina-FBS ka. Yung ano mo, yung FBS mo is 130. Tapos, tanong ka ng physician, anong oras ka kumain? Ganyan. Tapos parang, okay naman, pasok naman sa fasting yung ano. Pero parang di pa definitively sure yung physician na diabetes siya. Okay. On the other day, or another testing, or another check-up, ipapatesting ka ulit. Kung consistent na greater than 126 yung iyong FBS, that's basically a diagnostic na for diabetes mellitus. Okay? So presence of glucose in urine, glucosuria, ketosis, developed in DM from excessive synthesis of acetyl coenzyme A as the body aims to obtain the required energy from stored fat in the absence of an adequate supply of carbohydrate metabolites or lack of carbohydrate tolerance. Kaya gumagamit na ng ibang source for energy. Ito yung sinasabi ko sa inyo kanina. Okay? In severe DM, a ratio of beta-hydroxybutyrate to acetoacetate is 6:1. Guys, basically, BHBA and acetoacetic and acetoacetate or diacetic acid, they are ketones. Ang taas ng kapag severe DM na siya. Take note. Beta-hydroxybutyrate and acetoacetate and acetoacetate. Take note niya. What are the complications of DM? End-stage renal disease or renal failure. Kaya kapag yung isang patient nagkaroon ng diabetes mellitus, kapag end stage na siya, dialysis na yan. Hindi na gumagawa ng kidney. Okay? Non-traumatic amputation. Nagkakaroon ng nephropathy. Kapansin niyo sa paa, kapag nasugatan sa paa, mahirap maghilom. Okay? Kapag nasugatan sa paa, mahirap maghilom, nagkakaroon ng infection. Necrotic. Nagkakaroon na ng necrosis sa paa. Sometimes inuod, kapag hindi gumagaling, inuod yung paa, nagblabla, pero most commonly, nagmamanas muna pag nasugatan magaling. So ano yung solution? Amputation na yun. Tanggalin yung paa. Okay? Kasi kapag hindi tinanggal yung paa, kapag yung infection sa may area, sa may paa, naging systemic, magkakaroon ka ng sepsis, magkakaroon ka ng septic shock syndrome, mamamatay ka din. Okay? Kaya mas maganda para maagapan or ma-prevent ang systemic sepsis.
Sir, nakamute ka po.
Ayan. Sorry. Ayan. Okay, guys, since diabetes, di ba, one of the major is nephropathy or neuropathy. Yan. Parang mali sabi ko kanina. Kapag sa paa, neuropathy siya. Pag sa kidney, nephropathy. Okay? Lang yung mga patient na may diabetes. Our vital organs, they are affected. Okay? So, some diabetic patients are also complaining of loss of smell. Nabawasan mo yung smell nila, ganyan. Basically, lahat ng organs, if you have neuropathy due to diabetes mellitus, pwedeng magkaroon ng effect. Okay? Ganun yung ibig sabihin. Diabetic neuropathy or nerve damage. Okay? 60 to 70% of diabetic patients nabubulag pag hindi naagapan. Okay? 60 to 70%. Atherosclerotic disease. Okay? Atherosclerotic disease. Hyperlipidemia. Okay? Kasi nga, hindi nagugulam yung glucose. So, lalabas ang lipid. Okay? 2 to 4 times predisposition to heart and cardiovascular disease. Stroke, pulmonary embolism, ang ganyan, silang DM. Mas mataas ang risk kapag diabetic ka. Mataas ang risk ng stroke, sepsis, lahat. Criteria used to diagnose diabetes mellitus. Criteria. Okay. So at least dito ma-meet. FBS level is greater than or equal to 126 on at least 2 occasions. 2-hour postprandial glucose greater than 140. Mataas. Kasi kapag normal yung tao, tapos nag 2-hour postprandial, or ang ibig sabihin ng 2-hour postprandial, for example, kumain ka ng 8 a.m., i-measure yung glucose mo, or kukuha ka lang ng blood sample by 10 a.m. That's 2-hour postprandial. 2 hours after eating, kakalikan ka ng blood, testing yung sample mo. That's the 2-hour postprandial. Kapag mataas, sobrang taas pa din ng 140 after 2 hours, guys. Okay? Diabetes na yan. Symptoms of hyperglycemia, 3 P, yung 3 Ps. Polyuria, excessive urinating. Di ba nasabi lang sa natin sa biochem? Bakit ihi ng ihi? Polyphagia, kain ng kain. Polydipsia, laging uhaw. Unexplained weight loss, lipolysis. Casual or random blood glucose level of 200 milligrams per deciliter. RBS niya aabot ng 200. That's beyond the renal threshold. Kaya nagkakaroon ng glucosuria. Okay? So, nasabi ko na dati, pero ulit ko na lang ulit. Okay. Bakit kain ng kain? Si patient. Kasi, parang hindi na-acknowledge ng kanyang cells na mayroong glucose. So, the compensatory physiology of this disease is kumain ka. Kumain ka kasi nangihina ka, wala kang energy. Pero, meron ka palang glucose, hindi lang na-utilize or hindi lang na-tolerate kasi wala kang insulin. Since kain ka ng kain, ano mangyayari sa plasma solute? Tataas. Okay? Doon sa may solutions natin, that is termed as saturated solution. Okay? What's the next physiologic compensation? Since madami ang solute, iinom ka ng madaming tubig para ma-dilute yung solute sa plasma. Okay? To equilibrate the level. Okay? Since kain ka ng kain, tataas ang plasma solute, kailangan mo uminom. So, inom ka ng inom. Since inom ka ng inom, ano mangyayari? Ihi ka din ng ihi. And yung ihi mo na yan, may kasama ng glucose. Okay? Kaya kahit sabihin mong inom ka ng inom, ang expected result is mababa ang solute kasi nga inom ka ng inom. Well, mababa yung ibang solute, pero mataas naman ang glucose na sa urine. That's why mataas pa rin ang specific gravity. Okay? Huwag nyo kakalimutan yun. Ano yung itsura ng urine? Ano yung itsura ng urine ng isang diabetic patient? Ano yung color? Anyone? Ano yung color? Anyone from the class? Ano yung color ng urine ng isang diabetic patient na mayroong 3 signs na yan?
Yellow, sir.
Amber pa, sir. Cloudy, sir.
Miss Bato. It's clear. It's clear. Clear ang urine. Kaya ba nyo kakalimutan? Clear ang 5126. Ang urine. Guys, inom siya ng inom. Clear ang urine. Pero mataas ang specific gravity. Kaya nga yan yung yan yung parang exceptions doon sa relationship ng color and specific gravity. Because in normal urine, the darker the urine, the higher the specific gravity. Pero in diabetic urine, clear yung urine, pero mataas yung specific gravity. Huwag nyo kakalitan yun. That's one of the exceptions on the relationship of specific gravity and urine color. Huwag nyo kakalimutan yun na. Next one. 2-hour post-load glucose of 200 milligrams per deciliter in an oral glucose tolerance test. Familiar kayo sa OGTT? Ginagawa yan common sa mga buntis, OGTT. Ang ginagawa, papainumin ka ng glucose load, yung pure glucose, and then i-measure nila every hour kung gaano kataas yung glucose mo. Okay? Tinawag siyang oral glucose tolerance kasi how can you tolerate the glucose level given, how can glucose solution given to you? Kasi ang trend dapat dyan, in the first hour, nabawasan na. Habang alam patagal, every hour, pabawas dapat. Kasi that's how a normal metabolism is. If you can tolerate glucose per hour, pababa ng pababa. But, kapag diabetes yung patient, hindi siya bumababa. Or bababa man siya, sobrang konti lang. Okay? Yun yun to, 200 mg, ganyan pa rin kataas kapag diabetic yung isang patient. Exception to this criteria is the diagnosis of gestational diabetes mellitus or sa mga buntis. Okay, gestational DM. Okay? Ginagamit din kasi ang OGTT sa mga buntis, ginagamit din ang OGTT for the diagnosis of diabetes mellitus. Pero, yung criteria na 200 exemption ang gestational diabetes mellitus or diabetes mellitus episode in pregnant women. Okay. Types of diabetes naman tayo. Type 1, type 2, gestational, and the other specific types. So, hindi lang dalawa. Okay. By the way pala, napansin niyo yung trend, yung nag-trend sa Facebook dati. So, dito. According to some researches, Alzheimer's disease is now categorized as the type 3 diabetes mellitus, something like that. Type 3 na daw yung Alzheimer's disease kasi Alzheimer's disease is often accompanied by hyperglycemia. Study siya sa America. Hindi ko lang alam kung na-publish na siya sa 8th edition ng Bishop. Basta yun naman yung nakalagay. Okay? So, type 1, sa type 1, it's either immune-mediated or idiopathic. When we say immune-mediated, there is an antibody that targets the cells that produces insulin. Yung parang auto-antibody, ito yun. Yung auto-antibody. Okay? Siyempre kung masisira yung cells by the antibody, makakapag-produce ka ng insulin, hindi. Idiopathic naman, unknown cause. Unknown cause of diabetes mellitus. Pwedeng genetics. Yan, genetics commonly pag idiopathic. Yung parang hindi nila ma-explain kung bakit merong diabetes. Most likely, hereditary siya. Okay? Type 2 DM, adult onset DM. Gestational DM sa mga pregnant women. Other specific types of DM, genetic defects of the beta cell function. Ibig ng genetic defects of the beta cell function, the cell is not producing insulin properly kasi abnormal yung kanyang cellular makeup o yung kanyang protein makeup. Yan, mitochondrial DNA dysfunction, chromosome 7 glucokinase MODY2. Take note nyo to. Sa chromosome 7, glucokinase. Okay. Pag wala yan, pag mayroong defect, dito sa part ng chromosome na to, especially in relation to glucokinase, mataas ang levels ng glucose. Okay? Genetic defects of insulin action. Type A insulin resistance, leprechanism. Take note ito, leprechanism. When we say leprechanism, parang paiba-iba ng itsura. Insulin of insulin action. Drug or chemical induced hyperglycemia. Pentamidine. Beta-adrenergic agonist. Napansin nyo, kanina meron sila sa may hypoglycemic, meron din sila sa hyperglycemic. So, take note nyo yun. Some drugs are, they can alter the levels of blood glucose according to their specific pharmacokinetic properties. Okay? Immune-mediated, Stiffman syndrome. Take note nyo to, lumalabas sa compre, Stiffman syndrome, immune-mediated hyperglycemia. Ito yung pinaka-importante. Anti-insulin receptor antibody. Ito yung kanina, yung sinasabi ko sa inyong abnormal yung receptor, kaya hindi makapasok yung insulin and glucose sa loob ng cell. Kasi nga, the person is secreting autoantibodies directed to the insulin receptor at the surface of the cell. Kapag nasira yung receptor, makakapasok ba yung insulin at yung glucose? Hindi. Okay? Kaya, if we have this type of autoimmunity, mataas ang blood glucose levels. Okay? Criteria by the ADA or the American Diabetes Association. Symptoms and random blood sugar of 200 milligrams per deciliter, FBS of greater than 126, in 8-hour fasting, 2-hour OGTT of 200, and HbA1c of 6.5%. Ito na ulit lang ito kanina, nabanggit ko ito kanina. Diba? Dito tayo mag-focus. The normal level of HbA1c is around 3%. Okay, by the way, HbA1c, hemoglobin A1c, or the glycated hemoglobin. This is also known as the glycated hemoglobin. So lahat tayo, we have this HbA1c. Okay? So HbA1c, this is the sugar component of hemoglobin. Okay? So malalaman niyan, HbA1c, ito pala. Bakit parang nalagay ko dito? Mamaya na lang pala yan. HbA1c, basta HbA1c 6.5%. Type 1DM, marami siyang name. Insulin-dependent diabetes mellitus. Bakit tinawag siya insulin-dependent? Kasi wala na siyang insulin. Sinabi ko kanina, absolute negative ang kanyang insulin. That's why, para mabuhay yung isang patient na mayroong type 1DM, kailangan ng regular administration of insulin. By the way, kinukuha pala ng insulin, sinisynthesize ng insulin from pig intestine. Yung doon siya ginagawa. Yun yung laboratory-derived insulins. Okay? Juvenile onset insulin. Juvenile onset, makikita na yan sa mga bata. Kasi nga, mostly, hereditary. Brittle disease. Take note, brittle disease, aka ketosis-prone diabetes. Ketosis-prone. Mataas ang prones ng ketoacidosis sa mga type 1DM kasi nga, they produce no insulin at all. Absolute negative, kaya mataas ang risk nila ng ketoacidosis. Okay? And it's usually from autoimmune destruction of insulin-producing beta cells in the pancreatic islets causing absolute insulin deficiency. Autoimmune, hereditary, madami yan. 80 to 90% reduction in volume in the beta cells is required to induce symptomatic type 1 DM. Okay. Ganito kataas. Okay? Ganyan kataas yung yung reduction ng function bago ka magkaroon ng symptoms for DM. Kaya yung mga batang na ganito, usually they are inborn. Inborn na meron silang ganyan. Okay? Genetic susceptibility. Ayun, HL, sinabi dito pala yun. Genetic susceptibility is related to the inheritance of a specific immune response gene associated with HLA-DR, DR3, DR4, and DQ on chromosome 7 nang mamana ang type 1 diabetes mellitus. Okay? Naka-anchor ang gene ng diabetes mellitus sa HLA or the human leukocyte antigen DR3 or DR4 on the chromosome 6. Take note, doon siya naka-anchor. Kaya kapag merong diabetes on either one of your parent, most likely magkakaroon ka din ng diabetes. Ganun kalala, ganun kataas yung chance. Okay? Triggers events such as viral infection, toxin exposure, or stress may trigger the autoimmune destruction of beta cells. Trigger. Kapag autoimmunity yung case ng type 1 DM, viral infection, toxin exposure, stress may trigger autoimmune. Ano ba yung common denominator nila? Viral infection, toxin exposure, production of antibody. And sometimes that antibody, parang tawag dito, the antibody produced in these types of antigen presented in the body will mimic the antibody makeup for the beta cells. So parang yung na-produce, parang yung mapoproduce na antibody for viral antigens ma-redirect siya as an antibody for the beta cells in the pancreas. Ganyan. What are the markers for beta cell destruction? Paki-memorize. Lumalabas na board exam ito. Islet cell antigen 512 or the ICA 152. ICA 512. Okay, auto-antibodies lahat ito ha. The GAD65. ICA 512, GAD65. The IAA or the insulin auto-antibody. IA2, the tyrosine phosphatase like protein antibodies or insulinoma associated antigen 2 and 2 betas and 2 beta A. Yun yung kalimutan ng mga lagong lumalabas. These markers have used in familial studies where it was found out that at least 2 of these antibodies predispose an individual to develop type 1 diabetes. Kaya ibig sabihin mo, di ba sinabi ko sa inyo kanina, pagkapanganak ng baby, meron siyang diabetes. Dahil dito sa auto-antibody na itong mga to. Okay? They are triggered by viral exposure. Kasi tignan nyo naman, hindi lang isa yung antibody. Madaming class ng antibody. And these specific types of antibody affect specific parts of the cell. Okay? Hindi lang yung cell mismo yung tina-target ng antibody. Some antibody targets the glutamic acid decarboxylase enzyme in the cell. Okay? Some antibody targets the tyrosine phosphatase in the cell. Kasi kapag hindi complete yung function ng beta cell, hindi ka mag-produce ng insulin. It's just easy as that. Okay, ganun lang ibig sabihin nun. So lahat ng yung buong component ng beta cell, kapag hindi kompleto, kapag nagkaroon ng autoimmunity on either one of those components, you will not produce ample amount of insulin for metabolism. Ito lang yung ibig sabihin niya. Individuals with type 1 DM show low insulin and C-peptide level. Take note. Some books says low insulin, meron pa din na produce. Some books says absolute negative. Pero ang pagkakaparehas nila, meron pa ding na produce na C-peptide. Okay, ganun siya. Untreated type 1 DM can develop 2 ketoacidosis. Therefore, insulin therapy is required. Yan. Kapag yung isang patient na 40 years old, na medyo mataba, na merong diabetes, kapag hindi siya nag-undergo ng treatment or therapy, ang mangyayari dyan, papayat siya. Pero kapag yung isang matanda or 40 years old na medyo chubby, tapos meron siyang diabetes, tapos nag-insulin siya, most likely hindi siya papayat. Ganun yung indication niya. Kasi kapag hindi ka wala kang insulin, lipolysis, papayat ka talaga. Okay? Microalbumin of 50 to 200 milligrams in one day, the diabetic nephropathy. Okay. Diabetes mellitus, diabetic nephropathy, renal failure. Microalbumin of 50 to 200 milligrams in one day. Nagproproduce ka na ng low levels of albumin. Diba? Ang ano yung major indicator kasi natin ng acute kidney injury or renal failure? Proteinuria. Kapag nagkaroon ng proteinuria, delikado na yun. Kasi pwedeng sira na yung glomerulus. renal failure na yun. If you are tawag ito, if you are producing 50 to 200 milligrams of albumin per day, it is termed microalbuminuria. Okay? Tinawag siyang microalbuminuria or microalbumin kasi mababa yung levels ng albumin na nakikita. Pwede pa yung tumaas kapag advanced na yung stage. Okay? Signs and symptoms. Naisas ko na kanina. 3 Ps. Rapid weight loss, lipolysis, hyperventilation, mental confusion. Take note to ha, mental confusion. Parang symptom siya ng hypoglycemia, pero diabetic siya, hyperglycemia. Kasi hindi naman nagagamit yung glucose. So basically, kakapsot yung patient. And possible loss of consciousness. Ano yun? May term dito hyperketotic diabetic coma. There are instances na umaabot ng 500 milligrams per deciliter yung level. Hindi ko alam kung nilagay ko dito. Umaabot ng ganun kataas, 500 milligrams per deciliter. Isang indication nun, pwedeng makoma yung isang patient. Complications, mga pati-pati, retinopathy, neuropathy in the eyes, microvascular disorder. Ay sinabi ko sa inyo kanina, basta may neuropathy, yung mga organs, mababawas yung function, microvascular disorder. Neuropathy, parang wala namamanhid yung mga kamay, sa paa namamanhid, ganyan. Nephropathy, nasira ang kidney, diabetic nephropathy, okay? Idiopathic type 1 DM. Form of type 1 DM has no known etiology, kaya nga siya tinawag na idiopathic. Parang nagkaroon ka na lang ng type 1 DM, walang explanation. It is strongly inherited. Ito yung sinasabi ko sa inyo kanina, yung mga idiopathic inherited. It does not have beta cell autoantibodies and have episodic requirements from insulin replacement. Okay, habit. Type 2 naman, formerly known as non-insulin dependent DM. Tinawag siyang non-insulin dependent DM kasi meron din na produce na insulin pero konti lang. Adult type or maturity onset. Ito yung mga 40 pataas. Kapag 40 pataas tapos nagkaroon ka ng diabetes, that's type 2. Pero kapag kapamanganak mo tapos meron kang diabetes, that's type 1. Okay? Okay, stable disease. Stable diabetes. Kanina, brittle diabetes or brittle disease. Ketosis-resistant diabetes. Kasi, hindi ka masyadong produce ng ketones or keto acids kasi meron ka pa din konting insulin. Okay? Meron ka pa din konting insulin. Receptor deficient diabetes mellitus. Yan, receptor deficient diabetes mellitus. Meron kang problem sa reception ng entry ng glucose. Ano yung mga indication nun? Yung palaging tawag dito? Palagi kang hyperglycemia. For example, kain ng kain. Okay kasi mga carbohydrate-rich food. Okay, ganon. Kapag palaging ganon, parang at some point, na-desensitize yung receptor. Kaya nagkakaroon ng derangement. Okay? Ganon yung ibig sabihin niya. Receptor deficient diabetes mellitus or the RDDM. Yan. Receptor deficient diabetes mellitus. Nagkakaroon ng type 2 DM dahil sa sedentary lifestyle, kain ng kain, di nag-exercise. Yan. The type 2 DM has been described as a geneticist nightmare. Tinanong ko dahil ito kay Ma'am Alana, yung CI namin ng CC, bakit geneticist nightmare? Kasi, according to Ma'am Alana, hindi na mamap sa gene yung hindi na mamap sa gene itong disease na to. Yan. Parang bigla-bigla na lang sumusulpot, ganon, because of the receptor deficiency or receptor derangement. Okay? The most common type of diabetes. Yan. Type 1 diabetes is very rare. Take note niyo. Type 1 diabetes is very rare. Okay? But for type 2, this is very common. Siyempre, in our generation, like mga food natin, hindi na whole food, mga fast food, ganyan. Basically, later on, kung hindi tayo magbabago ng lifestyle, we will develop diabetes mellitus or naman sana. Okay? It is also a familial disease. Okay? Pwede itong ma-develop, pwede mamana. Okay? Obesity. What are the risk factors? Obesity. Yan. Okay. Underweight body mass index, less than 18.5. Normal BMI, 18.5 to 24.9. Overweight, 25 to 29.9. Obese, 30 above. Guys, lumalabas sa board exam. Lumabas yung obese sa board exam namin. Itong obese, kapag ganyan, kapag above 30 na yung body mass index or the BMI, merong, I forgot the computation, yung BMI, parang included ang height and then yung weight. I think yung height, parang height squared over kilogram. Ganun yata yung ng BMI. Pakita-check na lang, nasa bibigas naman, basta height and weight yung BMI. Okay? Kapag yung BMI mo, yes, yun ng 30, that's basically obese. Obese na yung isang patient. Okay? Okay, mataas ang risk kapag obese. Sedentary lifestyle, family history, advanced age, 40 pataas, ethnicity, take note, ethnicity, malaki yung chance. Okay? African American, Latinos, Native American, Asian Americans, Pacific Islanders, history of gestational diabetes, impaired glucose metabolism, hypertension, dyslipidemia. Individuals with the above factors are recommended for screening every 3 years of FBS. Yan. Kapag meron kayo isa dito sa inyo, it will not hurt if you will order FBS every 3 years kasi malaki yung chance, malaki yung risk. Okay? Ganyan. Every 3 years is screening. Kung meron kang hypertension or any metabolic disorder, kapag mayroong gestational diabetes, di sabihin nun, kapag buntis yung isang female, tapos hindi bumababa yung kanyang glucose, kapag buntis siya, pero after niyang manganak, bumalik na yung kanyang glucose level. That's basically gestation na. Malaki yung chance na mag-recur, magkaroon ng remission, yung hyperglycemic episode. Okay? What are the characteristics of type 2 DM individuals? Most are insulin resistant with relative or absolute insulin deficiency in insulin secretion. Okay? Most are obese. Tapos pumapayat kapag hindi nag-insulin therapy. Okay? They have an inappropriate high hepatic glucose production, glycogenolysis. They have impaired peripheral glucose utilization. Siyempre, they lack tolerance. They have decreased glucose transport in muscles and adipose tissue. That's why pumapayat. That's why nanghihina. Okay? Individuals are at risk of developing macrovascular and microvascular complications. Neuropathy, okay? Retinopathy, yan, mga ano. It has milder symptoms as compared to type 1 because type 1 kasi absolute negative. Pero pag type 2, relative siya or meron pa ding insulin. However, untreated type 2 DM will result to non-ketotic hyperosmolar coma. Ito pala yung term doon. Non-ketotic hyperosmolar coma. Hyperosmolar coma. Ibig sabihin ng hyperosmolar coma, from the word itself, hyperosmolar, sobrang taas ng solute concentration. Aabot ng 500. Ano naman yan? 500. Kahit naman sino dyan. Di ba? 500. Non-ketotic hyperosmolar coma. Pag-abot 500, kakoma ka na. Classification of DM. Summary. How will you differentiate type 1 and type 2? Pathogenesis. Type 1, autoimmune, hereditary, beta cell destruction. In type 2, insulin resistance. Meron kang insulin, sira lang, hindi lang maganda yung insulin, hindi lang Hindi lang fully functional yung receptor sa surface ng cells. Okay? Insulin resistance. Incidence rate, mas mababa, mas rare ang type 1, mas common ang type 2. Onset, juvenile sa bata. Onset for over 40 years of age. Okay? Genetics, autoimmune, genetic din, familial din, pero mostly sedentary or na-develop yan. Ano po yung isang doon? Ano po yung isang term? Familial and environmental factors. Yung obesity, lifestyle. C-peptide levels, detectable or undetectable or low. Di ba sabi ko sa inyo kanina, meron pa rin na produce ng C-peptide pero sometimes konti lang. In type 2 DM, detectable siya kasi nagproduce ka ng insulin. Okay? Nagproduce ka ng insulin pero yung receptor lang, yung problema, insulin mo, absolute negative. Or insulin, positive. Nagproduce pa rin yung pancreas pero dysfunctional. Kasi ano ba yung other term ng type 2 DM? Insulin resistance. Merong malfunction doon sa insulin receptor. Glucose. Siyempre, they are both diabetes. That's why they are both hyperglycemic. Glucagon. They are both hyperglycemic. That's why the glucagon is high. Pag mataas ang glucagon, mataas ang glucose. Yan. Mataas ang glucagon to stimulate hyperglycemia. Mataas ang glucose kasi polyphagia. Gluconeogenesis mataas. Kasi niya absolute negative ang insulin. Kaya mataas. Low to negative ang gluconeogenesis. Okay. Kasi nga, meron pa yung insulin. Ilan ang gamit ng maayos. Okay. Body type, thin, payat. Matataba itong mga type 2 DM. Pero, kapag hindi sila nag-undergo ng insulin therapy, papayat din sila later on. Pre-diabetes, autoantibodies, positive siya kasi nga autoimmunity siya. Symptomatology, abrupt kasi nga kapapanganak yan at wala kang insulin kaya mabilis makita yung symptom. Ito gradual. Gradual siya kasi after 40 years old, after that, magkakaroon pa lang ng symptoms. Okay? So kapag nahiipon ka na dyan, so kapag hindi mo binabantayan yung lifestyle, so basically that's a gradual onset. Okay? Ketosis, common, poorly controlled. Yan, kasi walang insulin. Rare. Rare ang ketosis sa type 2 unless hindi ka nag-undergo ng insulin therapy. Kasi nga, di ba, meron pa rin insulin. Medication, insulin, absolute. Oral agents like metformin. I think it's metformin or insulin. Depende sa case. Metformin or insulin. Pwedeng oral agents yung ibibigay, mga hypoglycemic like metformin. Pwedeng insulin therapy. Depende sa case ng isang patient. Okay? Kung depende sa origin niya. Okay? Pero ang common na ginagawang treatment for type 2 is oral agents muna, pero depende. Kasi may mga 40 years old na may diabetes, nag-insulin therapy sila. Like, alam niyo yung insulin syringe? Yung insulin syringe, color orange yung kanyang tsura. Tapos maliit lang yung kanyang needle at manipis. Isasaksak siya sa may fatty layer. Sa may fatty layer ng tiyan. Yung insulin. Others, ayan, dito pala. DR3 and DR4, yung immunology, namamana siya. Okay? Islet cell, ito yung mga antibody kanina, nabanggit na din. Ano yung mga increase BUN, blood urea nitrogen. Bakit kaya increase ang BUN? BUN, non-protein nitrogen, ang BUN. Non-protein nitrogen ang BUN. Okay? BUN, creatinine. Sa muscles lahat yan. Elevated osmolality, so increased glucose in the blood. Yan. Elevated osmolality, nagkakaroon ka ng mataas na osmolar gap. Literal lang yun sa inyo. DC2. Gestational DM, glucose intolerance during pregnancy. Sinabi ko sa inyo kanina, kapag pregnant yung women, they cannot tolerate glucose well. Kaya sometimes, napapansin ninyo, yung mga buntis, sinasabi nilang, ano yun, naglilihi or agminaw. But sometimes, gutom lang yun kasi baka meron silang GDM. Okay. Sinasabi nila na parang crave sila ganyan. Sometimes, it's a symptom of GDM. Okay? A disorder characterized by impaired ability to metabolize carbohydrate, usually caused by a deficiency of insulin, metabolic or hormonal changes. But commonly, hormonal ang GDM. Kasi nga nag-iiba yung hormones kapag buntis. FBS, 3-hour OGTT, 100 milligrams. One-step approach is the 2-hour postprandial glucose with 75 glucose load. Hindi ko nalagay dito. 75 glucose load siya. Ibig sabihin nun, parang with 75 grams glucose load. The 2-step approach, if positive, 1 hour postprandial glucose is greater than 140 milligrams per deciliter. That's the OGTT. Okay? So, itong nandito, ito rin lang siya. Nandito siya, sa may baba. Okay? So, ibig na sabihin. The glucose intolerance with onset or first recognition during pregnancy. Diabetic women who became pregnant are not included in this category. Ayan. Okay? First recognition during pregnancy. Take note niya. Screening. How will you screen for a GDM? 24 to 28 weeks of gestation. So basically, kapag 24 to 28 weeks, so parang, anong trimester siya? Parang 1, 4, 4, 4, 12. Parang second trimester. Yeah, right? Second trimester of pregnancy. 1 hour glucose challenge test. Take note nyo to, 1 hour glucose challenge test. Parang i-challenge mo yung patient if it can tolerate 50 grams of glucose. Okay? That's screening. A plasma glucose concentration of 140 milligrams per deciliter or greater requires a full diagnostic glucose tolerance test. Kapag screening, this is the screening, itong 75, itong 1 hour. Kapag pinainom mo ng 50 grams na glucose load, tapos yung na-measure mo sa sample ng buntis is 140, you are going to proceed to the full panel, OGTT. Yan, full diagnostic required na siya. That's the 3-hour. Okay? With, ano gagamitin? 100. Pag screening, 50. Pag full diagnostic panel, 100. Okay. So, papainamin mo ng ano? Papainamin mo ng 100 glucose solution. 100 grams glucose solution. Okay. Sa first hour, kapag lumagpas ng 180, proceed sa second hour. Ayan. Kapag lumagpas ng lumagpas ng 155 sa second hour, stop. Diagnostic na siya. Okay. Okay. So kapag sa first hour is 170, proceed. Second hour 160, proceed. Third hour 150, diagnostic for GDM. Kasi what's the protocol? GDM is diagnosed if 2 plasma of the above glucose levels are exceeded. Kahit dalawa lang dyan. Kahit dalawa dito ang lumagpas sa level, diagnostic na siya for GDM. And take note, yung buntis, dapat yung kanyang fasting blood sugar is less than 95. Dapat yung kanyang FBS para hindi siya categorize. Okay? Ano lang ibig sabihin nun. Kapag ano naman, kapag yung kanyang FBS is 130, yung kanyang 1 hour OGTT is 190, diagnostic na yun. Okay? Diagnostic na yun. Kasi according dito, kahit dalawa lang dito, sa apat na yan. Sa apat na yan, ano na siya? Diagnostic na siya. Okay? After giving birth, women with GDM should be evaluated 6 to 12 weeks postpartum. Ano ibig sabihin nun? Postpartum. After ka mapanganak, parang daily check up siya. And daily check up, parang check up siya after 6 to 12 weeks para malaman mo if the glucose levels ay bumalik na sa normal or mataas pa din. Delikado yun kasi pwede siyang mag-proceed into type 2 diabetes mellitus. GDM can proceed into type 2. Naman kasi yung indication niya. Infants born to diabetic mothers are risk for RDS, hypocalcemia, and hyperbilirubinemia. Take note nyo to. Respiratory distress syndrome, hypocalcemia, and hyperbilirubinemia. Kapag diabetic yung mother, ito yung risk. Kaya sometimes kapag i-evaluate ng OB-GYN yung isang pregnant mother bago manganak, tinitingnan, in-interview na nila, dapat alam nilang diabetic yung mother para the care unit, the hospital will prepare all the necessary materials para mabigyan ng aid agad yung baby magkalabas sa womb ng mother. Kapag diabetic kasi yung mother, expected na mayroong respiratory distress syndrome. So, pwede mag-prepare ng any respiratory machines for care dun sa baby. Ganun lang. Okay? Guidelines for administration of OGTT. Okay. Patient is asked to consume at least 150 grams of carbohydrates for 3 days. Take note, 150 grams for 3 days. Guys, nung nag-aaral ako, medyo hilong-hilo ako dito. Kasi meron kang 75 grams. Tingnan nyo dito kasi. Meron kang 75 grams for 2-hour postprandial glucose. Meron kang 50 grams for 1-hour glucose challenge test. Meron kang 100 grams for the 3-hour full panel. And then meron kang 150 grams of carbohydrates intake for 3 days. Yan, huwag kayong malilito. Merong 75, may 50, may 100, may 150. Magkakaiba sila ng gamit. Okay? For 3 days. Patient is asked to avoid excessive physical activity and do overnight fast. Kapag kasi nagkaroon ng physical activity, parang magkakaroon ka ng falsely low glucose level. Okay? Measure fasting glucose level before giving glucose. Parang baseline. You will be needing your baseline. Okay? That's why you're going to measure the fasting glucose before giving 100 grams of glucose. Okay? If fasting glucose is 140, terminate. Dalawang indication yan. Hindi siya nag-fasting or meron siyang diabetes. Yan. Kapag yung fasting niya is 140 above, diagnostic na yun. May diabetes na yung isang patient. If fasting glucose is less than 140, administer 100 grams of glucose, proceed sa full panel 3-hour OGTT. Okay? What are the criteria for diagnosis of DM using OGTT? Fasting glucose of 140 or above, no OGTT required. Diagnostic na siya. 2-hour values and one other value, both 200 milligrams per deciliter. Impaired glucose tolerance test is considered to be present if the 2-hour value of 140 to 200 milligrams per deciliter and one other value of 200 milligrams per deciliter. Ayan. Paano yan? Okay. Tignan nyo to. Okay. So, impaired glucose tolerance test is considered if to be present if the 2-hour value of 1 hour, to the 2-hour value of 140 to 200, tignan nyo dito, sa may 2 hour, dapat less than 155. Kapag above 155, diagnostic na siya. And other value, 200. Kapag nag-200 si 1 hour, kapag naging 200 or 140 to 200 si 2 hour, diagnostic na yon. Kaya parang kanina lang din, kahit dalawang plasma yung above sa per hour interval ng OGTT, diagnostic na siya. Okay? Don't be confused ha, kasi magkaiba kasi ng source ito. Ito yung source dito iba. Itong 140 to 200 sa 2 hour. Tapos dito, na 2 hour na 155. Basta ang isipin na lang, sa may 3 hours kasi parang common sense. Kasi kapag hindi pa bumaba ng 140 sa 2 hour, syempre mataas na din yung glucose niya. Okay. So ito, ano na lang, memorize. Okay. Resting plasma glucose or the RDS. Okay, resting plasma, random. 140 to 200. Okay? Above 200, diabetes. 140 to 199, that's impaired. Kapag sinabing impaired glucose value, parang borderline siya, parang warning sign. FBS, 100 to 126. Some is 90 to 126. Basta ang isipin ninyo, itong 126. Pag nabanggit ang FBS, 126. Ang normal na FBS, less than 126. Yun lang yung tatandaan. Above 126 or greater than or above 126, diagnostic siya for DM. Lalo na kapag umabot siya ng 140. Okay? 2-hour OGTT, nasa ano kanina, nasa value din naman, 140 to 200, parang yung kanina. Hemoglobin A1C, normal is below 5.7, around 3%, normal siya. Okay? Kapag umabot ng greater than or equal to 6.5, diagnostic na siya for diabetes mellitus. Okay? Dito ba yun? Ano, wala, hindi ko nilagay. Saan ko nilagay yun? Baka sa love. Okay. So, napansin niyo yung pinaano ko sa inyo na what's glycated hemoglobin or HbA1c and fructosuria, they are used as a fructosamine, they are used as a glucose control. Fructosamine, ano siya, parang 2 weeks glucose control. So parang kapag may-measure mo yung fructosamine mo ngayon, malalaman mo yung glucose level mo last week. Ganyan. For HbA1c, long-term ano siya, long-term glucose control ang HbA1c. Kasi ang HbA1c, yung sugar na yon located siya sa hemoglobin. That's why the lifespan of HbA1c is related to the lifespan of the RBC. So basically 120 days. Ganun yung control. Okay? Ginagamit siya sa monitoring. For example, merong diabetic yung isang patient, para malaman mo na gumagana yung treatment mo sa patient, if you're going to conduct HbA1c tapos normal na siya, ibig sabihin nun, for the long term, gumagana yung treatment. Okay? HbA1c, glycated hemoglobin, less than 5.7%, that's the normal. Above that, especially 6.5, that's indicative of diabetes mellitus. Hindi nyo kakalimutan. Okay. Glycated hemoglobin, 120 days. Kaya siya, long-term glucose control, yung HbA1c. Carbohydrate intolerance. Lactose intolerance, marked decrease in lactase. Diarrhea, yung nagatas, pagtatae, hindi ma-tolerate kasi wala kang lactase. Patient fast overnight, lactose tolerance test. We have LTT naman dito, hindi siya OGTT. Lactose tolerance test, oral lactose is administered 50 grams in 200 to 300 ml of water, and then the blood samples are taken every 20 minutes for 2 hours. Take note, 20 minutes for 2 hours. So basically, 1 hour, 1 hour, ilang 20 minutes ang 1 hour? 3? 3, tatlong 20 minutes in 1 hour. So basically, in the whole testing, in the whole testing, parang you are required to be extracted mga 6 times. Result, normal lactose tolerance if glucose level rises 25 milligrams per deciliter or more than above the fasting level, the patient has normal lactose tolerance. Ibig sabihin no, naa-absorb mo yung glucose, kaya tumataas yung level sa blood. Rises. Nagkakaroon ng diarrhea and gastrointestinal disorder or gastrointestinal discomfort kasi hindi mo na-absorb si lactose kasi wala kang lactase. Ano yung ibig sabihin nun? If you can tolerate lactose, ibig sabihin nun, you can absorb lactose. Ano yung ibig sabihin nun? Presumptive. If glucose level rises less than 200 milligrams per deciliter, it is a presumptive evidence of inability to convert lactose. Yan. Okay. Presumptive lang siya kasi hindi siya direct lactose measurement. This is a glucose measurement. Pero, if glucose level rises less than 20 milligrams per deciliter, it is a presumptive evidence of inability to convert lactose. Presumptive siya kasi indirect measurement. Okay? What are the causes of lactose intolerance? Congenital or acquired. Pero ang alam ko, ano siya? Kapag congenital, ano to? I think acquired. Kapag acquired, parang celiac disease. Alam niyo yun? Or gluten enteropathy. Parang meron din siyang sequelae na lactose intolerance. Okay? For congenital, mamana. So basically, if sa inyo, uso ang lactose intolerance or LI, basically, mamamana nyo din ang LI. Okay? Galactosemia, more serious than lactose intolerance kasi it can cause cataracts and mental retardation at early age. Parang part siya ng inborn error of metabolism dun sa screening panel. Yes pala, part siya. Familiar ako sa enzyme, the G1 put. Lactose 1, phosphate uridyl transferase. Part siya ng newborn screening. Okay. Nagkakaroon ng cataract and mental retardation sa mga baby kasi galactose will be deposited in the microvasculature. Kung nagkaroon ng deposition, kakaroon ng cataract. Kakaroon ng mental retardation at an early age. That's why, kailangan malaman after kapapanganak ng baby if yung mga ano natin, yung inborn error of metabolism according to RA 6428 yata. Diagnosis, increased liver enzymes due to galatidol, ALT and AST, tumataas yan. Kasi you cannot tolerate eh. Elevated bilirubin, presence of reducing substances in the urine or urine galactose. Bakit kaya overloading ito? Kasi nangyari dapat, galactose will be broken down into simpler units. Pero, since hindi mo na broke down ang galactose, nagkakaroon ng plasma overflow. Kapag nag-overflow yung solute level sa plasma, mangyayari, pupunta sa urine because urine is the ultrafiltrate of plasma. Okay. Next one, elevated G1 put in RBC. Take note nyo ha, saan nakikita ang G1 put? Elevated G1 put in RBC, pero enzyme deficient siya sa serum. Essential fructosuria, wala siyang fructokinase deficiency. Fructokinase catalyzed conversion of fructose to fructose 1-phosphate. Diagnostic indicator, fructosuria. Parang galactosuria din lang siya. Okay, wala sila ng metabolite. Okay? Wala kang fructose 1-phosphate. Glycogen storage disease. Parang Okay. Okay. Glycogen storage disease. This disease is consequence of inherited deficiency of enzyme that controls the synthesis or breakdown of glycogen. Abnormally quality or quantity of glycogen is found in these disorders. Nagkakaroon ng deposition sa mga organs or tissue. Kasi nga mayroong enzyme deficiency. Okay. So, memorize na lang ito lahat. Na kay Dean Rodriguez naman ito. Nasa 2014 version ni Dean Rodriguez. Basta kapag nabanggit ang enzyme, most commonly, related siya sa liver. Di ba? Liver, synthesis of protein, synthesis of enzymes. So basically, yung kanyang mga tawag dito, clinical features like hepatomegaly or enlargement of the liver, cardiomegaly, enlargement of the heart, myoglobinuria, kapag related sa muscle, ganun. Madali na naman siyang intindihin. Kapag may nakita kayong mga cyclic AMP, mga glucose transporter, glucose glycogen synthase, parang part siya ng glucose metabolism and Krebs cycle. So basically, hepatomegaly. Okay? Pero dito sa glycogen synthase, no hepatomegaly, pero hypoglycemic yung symptoms kasi hindi siya nakapag-produce ng glycogen from glycogen synthase. Okay, take note niyo. Parang yun lang. Causes of abnormal glucose levels, hyperglycemia, and hypoglycemia. Parang ito yung pinaka-overview ng lesson. Okay? Hypo and hyperglycemia. So we can categorize them according to into two, persistent and transient. When you say persistent, hindi siya nawawala. When you say transient, this is temporary. Temporary hyperglycemia. Okay? So paki-memorize na lang ito. DM, Cushing syndrome, hyperthyroidism, acromegaly, obesity. Transient hyperglycemia, pheochromocytoma, or tumor in the chromaffins. Basta catecholamines. Basta ito yung tumor na nagsisecrete ng catecholamines something. Severe liver disease, acute distress reaction, shock, convulsions. So ito yung mga stress related. Persistent, hypoglycemia, insulinoma, Addison disease, hypopituitarism, galactosemia, ectopic insulin production of tumors. Transient, hypoglycemia, yung mga intake like alcohol ingestion, drugs, antipyretic, antibacterial or antibiotics, anti-TB agents like rifampicin, isoniazid, ethambutol, mga ganon. Severe liver disease as well. Several glycogen storage diseases, functional hypoglycemia, hereditary fructose intolerance. Okay? Yun lang. Yung mga tanong, I know, masyadong madami kasi yung lecture na ito dapat, 2 meeting, pero wala. Wala pa naman pala kayo sa glucose sa lecture ninyo. Kasama to sa midterms. Okay, may isa pang module. Wait lang. May isa pang module. Sa methods. Yes. Ano kasi, diabetes insipidus, more like a topic siya for clinical microscopy sa urinalysis. Urinalysis siya. Pero, yes, urinalysis. Kasi ang difference ng DM at DI, katawag ito, doon lang sa water retention lang naman yung problema dito. Bigger na lang yun sa, ano niya, sa inyong CM. Wait lang, 3-minute water break. 4 minutes lang naman ito. Pagod mo ako. Or gusto niyo basahin, or gusto niyo basahin niyo na lang itong method, gusto niyo, or i-explain ko pa. Paano kaya naman na siyang basahin? Sige, mamaya after 3 minutes. May mga
Explain na lang, sir.
Ano? Okay, sige.
Explain na lang po.
Sige, after 3 minutes, wait lang. Okay, let's resume. Kaya pa? Okay, start na natin. Okay, carbohydrate methodologies. Okay. So, methods. FBS, 8-hour fasting. Normal value, 80 to 126. Okay. That's the normal value for FBS. POCT, ito yung ginagamit, ito yung ito yung mga glucometers. Strips used are impregnated glucose oxidase and peroxidase. Reflectance meter, ito yung principle niya. Reflectance meter. Kasi magkakaroon din ng color reaction sa strip, and then yung yung glucometer, i-measure niya kung gaano ka-intense yung color based on the oxidase reaction, based on the oxidase-peroxidase reaction sa glucose. Kung nagba-brown, nag-blue, nag-light blue, ganyan. Yung principle ng glucose oxidase dito, glucose oxidase and peroxidase, doon sa strip for whole blood capillary puncture, same lang siya sa principle ng urine strip, kung naalala ninyo. Okay? HemoCube, transmittance photometry and single test cartridge based on glucose dehydrogenase method. Okay. Ito yung ginagamit sa strips, okay? Sa urine strips. Some yung ginagamit din sa strip ng glucometer, glucose oxidase din. Okay, huwag niyo kakalimutan yan. Okay. 2-hour postprandial. Solution containing 75 grams for adult and 1.75 gram per kilogram in children. Take note niyo yan, magkaiba. 1.75 grams per kilogram. So, kailangan i-compute kung ilang kilo, kung ilan yung kilo ng isang pediatric patient. Okay? And the specimen is drawn 2 hours later. The normal 2-hour postprandial must be less than 140. Diba? Para siyang ito yung value ng 3-hour OGTT. Pero dito kasi 75 grams siya. Sa 3-hour OGTT, that's 100 grams. Hindi kakalimutan. Kapag umabot ng 180 above, that's basically diabetic yung patient. Yan, diabetic na siya. So magkakaroon na ba ng glucosuria? Karoon na, because this is basically the renal threshold of glucose in the urine. Okay? HbA1c, dito pala. Index of long-term plasma glucose control, 2 to 3 months period, kasi naka-align siya sa lifespan ng RBC, indicating compliance and efficiency of diabetes therapy or the average plasma glucose level. Glucose is attached to hemoglobin 2. Parang long grammar. Glucose is attached to the hemoglobin as ketoamine. Specimen. Yan. Kapag tinanong sa inyo, what is the most common whole blood specimen in clinical chemistry? Kasi kapag sinabing clinical chemistry, laging serum. Laging serum yung Laging serum yung yung specimen. Pero kapag nakakita kayo ng EDTA sa clinical chem, most likely HbA1c yung test na gagawin. Okay? Yung specimen for CBC, pwede siyang gamitin for hemoglobin A1c. Pero ang HbA1c, ginagawa siya sa CC, hindi siya ginagawa sa HEMA. Ano yung principle for HbA1c? Pag-take note, yung principle na na-encounter ko sa San Lazaro dati, yung ginagamit na machine for HbA1c, it's microelectrophoresis. Microelectrophoresis yung ginagamit. Kasi HbA1c is a variant of hemoglobin. So basically, if you're going to do electrophoresis, you're going to separate different variants of hemoglobin and then i-quantitate mo yung HbA1c. So i-fractionate mo yung buong hemoglobin based on their category, like hemoglobin F, hemoglobin A2, hemoglobin A1c, hemoglobin C, hemoglobin S. Yung HbA1c, yun lang yung i-quantitate ng electrophoresis. Okay? No fasting required. Kasi hindi naman siya sa serum or sa plasma. And this is a long term at nasa loob siya ng RBC. Kaya no fasting required. Ketones. Product of fat decomposition produced in the liver. Rapid fat metabolism or rapid fat catabolism, rapid lipolysis, and product ketone. What are the 3 ketones? The acetone, acetoacetic acid, or the diacetic acid, and the 3-BHBA or the 3-beta hydroxybutyric acid. Tingnan nyo naman, mga acid itong mga to. That's why elevated levels of these analytes in the blood will cause ketosis or metabolic acidosis. Take note, pinakamataas si beta hydroxybutyric acid. Okay? Acetoacetic acid, ito yung nade-detect. To detect acetone, kailangan ng glycerin yata sa reagent. Microalbumin, diagnosis of an early age of diabetic renal nephropathy and before the development of proteinuria. Yung sinabi ko sa inyo kanina, ito yung parang window period to observe advanced renal disease or the ARD. Okay? Persistent albuminuria in the range of 30 to 299 milligrams per day, or the AC ratio or the albumin-Crea ratio of 300 to 3,000 micrograms per milligram, that is considered microalbuminuria. Kapag hindi naagapan yung signs ng microalbuminuria, pwede siyang mag-proceed into nephrotic syndrome. Hindi nyo kakalimutan yun. OGT, huwag nyo kakalimutan. Patients' fasting blood glucose is taken after a glucose load. Okay, huwag nyo kakalimutan. Kaya siya tinawag na oral glucose tolerance. How can a person tolerate glucose based on the grams of glucose administered before blood glucose measurement? Glycomark blood test. Take note nyo to. Measures 1,5-anhydroglycitol, a monosaccharide that is very close to chemical structure to glucose. Monitors glycemic control for 1 to 2 weeks. Yan. Ito pa, sorry guys, maling nasabi ko kanina. Ito pala yung 1 to 2 weeks. Yung fructosamine, ito yung 1 month. Okay? Ito yung 1 month na glucose control. So yung pinaka matagal, it's the HbA1c, 2 to 3 months, 3 months. Fructosamine or the glycated albumin, 1 month. Nakadepende kasi yung half-life ng fructosamine sa half-life ng albumin. Same lang din. Ang albumin, yung half-life ng albumin, most likely 1 month din. Kaya kapag nagkaroon na ng albumin, syempre mawawala din yung half-life ng fructosamine. Okay? Reference value of fructosamine, 205 to 285 micromole per liter. Take note, micromole per liter. Okay? Okay, sa methods na tayo. Okay, we have, wait lang, enzymatic method. These are colorimetric, I think. Yes. Non-enzymatic method. And they are also colorimetric method. Okay? Hindi na ito, sa India, ito bago kasi na-encounter natin ito sa biochem. Sa biochem, na-encounter natin ito sa biochem. Okay. Alkaline kappa reduction method. Kapag nabanggit ang alkaline kappa reduction method, parang the glucose being a reducing agent reduces copper ion in an alkaline medium. Kaya nga siya tinawag na alkaline kappa reduction method. Okay? So the glucose is, take note nyo to, lumalabas sa board exam. Glucose is 5 to 15 milligrams per deciliter higher because of the presence of other reducing substances such as urea in the serum or plasma. Kung i-compare nyo sa enzymatic kasi, enzymatic is specific. But for non-enzymatic, hindi siya specific. It is solely dependent on the reducing properties of analytes present in the sample. Okay? Automated chemistry analyzers measure by color change of series of coupled chemical reactions or by consumption of oxygen of an oxygen sensing device. Ano yan? Ano yung oxygen sensing device na yan? Clark electrode. Pwede din ginagamit dyan. Okay? Calculate glucose by rate of reaction, which is proportional to the concentration of glucose. Yan, rate of reaction and glucose, yun lang din. So we have 4 subcategories: the Nelson-Somogyi, Follin-Wu, Neocoplone, and the Benedict's method. Pinaka-common si Benedict. Lagi itong nababanggit, di ba? Okay. So detection of quantification of reducing substances in body fluids like blood and urine. Na-encounter commonly ang Benedict's method sa urine. Di ba yung estimate? Yung color from blue, mag-green, mag-orange, mag-red. Okay? Stabilizing agent. Hindi ito common na in-emphasize sa CC kasi sa CM siya na-encounter. The sodium citrate and tartrate. Ito yung ingredient ng Benedict's test. Sodium citrate, alkaline tartrate, yung mga ingredient ng Benedict's reagent. Okay. Nelson Sumog G. Copper reduction siya. Uses barium sulfate to remove saccharoids. Take note. Saccharoids are interferences. One way to remove saccharoids are using barium sulfate. Okay? So yung reaction niya, glucose plus arsenomolybdic acid produces arsenomolybdenum blue. Ano yung end product niya? Siyempre blue. Kasi nga arsenomolybdenum blue siya. Okay? For the following mo naman, phosphomolybdate. So phosphomolybdenum blue. So basically, yung mga reactants for glucose oxidase, they are acids. Okay? It helps in the reducing property. Okay? Neocoproin. Ito lang yung naiiba. Okay? Kasi Nelson Sumog G, Fallin Wu, para silang blue. Pag Benedict's test, nagre-red. Nagre-red siya. Pero dito sa tatlong, between Nelson Sumog G, Fallin Wu, and neocoproin, si neocoproin, nagkakaroon siya ng complex. Okay? From the word itself, neon, isipin nyo lang yung neon. Di ba parang may makulay. Okay? Complex siya from yellow, yellow-orange, pwedeng slightly greenish. That's neocoproin. Okay? Because the reagent here is neocoproin. And take note nyo, coproin din siya. Copper derivative. So, nag-yellow din siya. Okay? Hagedorn-Janssen. Ito yung pinaka-unique sa mga methods. Because Hagedorn-Janssen is a reverse colorimetry. Sabihin nun, yung end product niya is colorless. Unlike for the colorimetry na mag-produce ng color blue, mag-produce ng color red, color orange, ito, from the colored reactant to a colorless product. That's why it is termed as reverse colorimetry. Pero yung kanyang principle, reduction. Pero take note nyo ha, ferric reduction, hindi siya ferrous reduction. So parang Fe3 magiging Fe2. Unlike Fe2 to Fe3 na magre-red, Fe3 to Fe2 magiging colorless. Okay? Glucose plus ferricyanide, which is yellow, it will turn into ferrocyanide. Diba ferri 3+, ferro 2+. So magkakaroon ng colorless end product. Okay? Orthotoluidine or Dubowski. Okay. Orthotoluidine or Dubowski, ito yung ginamit. Ito yung principle ng proofing reagent na ginagamit namin nung undergrad kami, itong orthotoluidine or Dubowski. Condensation of carbohydrates with aromatic amines producing Schiff's bases. Take note, kapag nabanggit ang orthotoluidine, condensation ang pinaka-principle ng orthotoluidine or Dubowski. Para hindi niyo makalimutan, di ba? Orthotoluidine, Dubowski, condensation. Basta yung madaming O. Madaming O na word for glucose, isa lang yan, orthotoluidine, Dubowski, condensation. Isa lang yan. Okay? Enzymatic method naman tayo. When we say enzymatic method, this is specific for glucose only. Okay? Okay, specific siya for glucose, but their specificity vary on the enzyme. Okay? Dito. First one, glucose oxidase. It measures beta-D-glucose. Okay. So beta-D-glucose plus oxygen plus water catalyzed by glucose oxidase produces gluconic acid plus hydrogen peroxide. Okay. So this is the first reaction. Okay. Kaya siya coupled enzyme eh. Glucose oxidase Glucose oxidase, peroxidase. Yun kasi yung ano niyan, hindi mo nasabi dito. Basta glucose oxidase, peroxidase, they are combo. Lagi silang combo. Kaya ang term sa AUBF, ang glucose oxidase, peroxidase is the double sequential enzymatic reaction kasi series. It's a series. After oxidase, merong peroxidase. Because on this reaction alone, walang color yan. The first reaction in the series produces no color. Upon addition of hydrogen peroxide, yan, siya rin ito, itong hydrogen peroxide. Upon addition of hydrogen peroxide and reduced chromogen together with the gluconic acid, tapos catalyzed by peroxidase. Itong reaction na to, ito, yan, tapos ito, isa lang yan ha, magkakakonect lahat yan. Yan. Catalyzed by peroxidase, magkakaroon ng chromogen. Ito siya. Magkakaroon ng chromogen. Magre-red, slightly red, mag-blue. Depende sa intensity or depende sa kung gaano kadami yung glucose sa specimen. Okay? So take note, what's the reduced chromogen on the double sequential enzymatic reaction? It's the orthodianisidine. Orthodianisidine. Okay, take note niyo yan. For urine and whole blood glucose, rapid testing, strip testing. Sabi ko sa inyo kanina. Urine strips. Sa glucometer, via capillary puncture, same principle. Used for automated methods for plasma and glucose and serum. Yes. Ano ba yung sinabi ko sa inyo dati? Glucose oxidase is the most common dito tayo sa oxygen consumption using glucose oxidase. Okay. Okay. So dito sa oxygen consumption, ang mini-measure lang is the production of oxygen. The oxygen produced is directly proportional to the amount of glucose present. Okay? So, dito H2O2, kapag na-breakdown ang hydrogen peroxide, ano yung kanyang product, di ba? Water and oxygen. Right? Yes, water and oxygen, di ba? So, kapag na-breakdown itong H2O2 via gluconic acid using hydrogen peroxide, using peroxidase, magproproduce ka ng oxygen. The consumption is measured by oxygen electrode or the polarographic electrode or the Clark electrode. Okay? Hindi nyo kakalimutan. This is less common than isokinase method used for glucose meter testing. Accurate and precise method, virtually no interferences. Pero rare itong ginagamit. Kasi hindi naman lahat ng laboratory merong electrode for oxygen. Okay. Next one, hexokinase. This is the reference method or the gold standard for glucose testing. Okay, so glucose plus adenosine triphosphate catalyzed by hexokinase will produce the G6P plus ADP. Okay. Kung napapansin ninyo, parang ito yung pinakauna-unang sequence doon sa glycolysis. Doon sa glycolysis, di ba? Kung napapansin ninyo sa glycolysis. So from the product, G6P plus ADP catalyzed by glucose 6-phosphate dehydrogenase. Ito yung mga enzymes yung mga nakaano, parentheses, will produce a reduced NADPH plus hydrogen plus 6-phosphogluconate. Ano yung minimeasure ulit dyan? Yung sinabi ko sa inyo. Yung minimeasure dyan, yung NADPH. Absorbance, 340. Yan. 340. So, ang 340, ano yan? Sa UV. Sa UV yan, di ba? Take note nyo ulit. Ano yung mga ginagamit na light? Yung mga ginagamit na lights for UV. For UV readings. Yun na lang yan. Ang maganda dito sa hexokinase, it is not affected by ascorbic acid or uric acid, unlike sa glucose oxidase, na affected siya. Yung sinabi ko sa inyo dati, ano yung limang parameters sa urine affected ng high levels of ascorbic acid, di ba? Blood, bilirubin, leukocyte, esterase, nitrite, and glucose, affected sila ng ascorbic acid. Mababa sila. Okay? Mababa ang count kapag merong ascorbic acid. Gross hemolysis and elevated bilirubin may cause a false decrease in result and gross hemolysis. A specific glucose method which employs G6PD as a second coupling step requiring magnesium. What's the magnesium here? It's an activator or it's a metalloenzyme. Magnesium. Okay? Kailangan ng magnesium to the process. Okay. Next naman, glucose dehydrogenase. Same lang din. Parang same lang din sila dito sa hexokinase, but instead of using adenosine triphosphate, dito gumagamit ng NAD, nicotinamide adenine dinucleotide, catalyzed by glucose dehydrogenase to produce NADPH and hydrogen and D-glucogylactone. Yung minimeasure ulit is NADH. Ito yung mga minimeasure na analyte. Okay? Okay, so the mutarates. Okay. Method for the diagnosis of metabolic alteration shortens the time of the test. Mutarates. Okay. Okay. Kasi most of the methods kasi compatible siya with the yung nasa dextrorotatory glucose. Kapag hindi ganun yung orientation ng glucose, pwedeng ma-miss out. That's why using mutarates can prevent that phenomenon. Okay. Next one. Glucose oxidase, glucose peroxidase oxidase. Parang baliktad dito. Dapat glucose oxidase, peroxidase. Okay. Increased uric acid, ascorbic acid, bilirubin, tetracycline, hemoglobin, and glutathione will falsely low glucose levels. Tingnan nyo to, itong mga affected ng enzymes. Ng mga enzymatic tests. Okay? Hemoglobin. Kaya sa mga face-to-face at sa glucose nyo, di ba sinasabi ko na hindi dapat may hemolyze kasi kapag na-hemolyze yung sample, lalabas yung hemoglobin sa loob ng RBC and RBC will falsely decrease the reading. Okay? Kapag naman photometry, kapag masyadong dark yung red, pagka-red ng serum, pwedeng tumaas kasi nga yung intensity ng color. Yan. Urine lipstick method. Glucose oxidase and chromogen. Okay? Pero some books, glucose oxidase peroxidase yung nandun. Okay? Basta meron ang glucose oxidase. Color observed and compared with standard color chart that is equivalent to glucose in the sample. So the color ranges from, depende sa manufacturer ranges from blue to brown, some naman parang red to blue, depende sa manufacturer. Okay, last na to. Fasting glucose in whole blood is 12 to 15% lower than serum or plasma. Tinanong ko sa inyo, tinanong ko sa mga face-to-face itong statement na to. Mas mataas, ay hindi pala, doon sa itong venous blood is 7 milligrams per deciliter lower than capillary blood and arterial blood. Mas mataas ang glucose level sa artery compared sa venous, sa vein. Okay? Kasi this is explained by the glucose turnover. This is explained by the glucose turnover issue. Okay? Diba kasi nga kapag mayroong glucose turnover, sa artery, madaming glucose doon. And then, upon exchange of oxygen and glucose for metabolism, nababawasan. And then kapag pupunta na siya sa may vein, bawas na. Kaya mas mababa ang venous blood glucose level compared sa capillary. Next one naman, fasting glucose in whole blood is 12 to 15% lower than serum or plasma. Common sense. If you're going to compare plasma glucose and whole blood glucose, mas mababa talaga ang whole blood glucose kasi meron siyang blood elements. That's ba? Meron siyang blood elements. Kaya if you're going to measure glucose alone, parang dadagdag siya sa may source, dadagdag yung blood elements to the solution composition if you're going to compare it with the same volume. Okay? Room temp, glucose level decreased by 7 milligrams. At ref temp, 40 degrees Celsius, glucose levels decreased by 2 milligrams. By the way, kapag nabanggit ang room temp, 25 plus minus 2 degrees Celsius. So basically, mga 23 to 27 degrees Celsius ang room temp. Pag nabanggit naman ang ref temp, 4 degrees agad. Ito yung constant ref temp. Okay, sa blood banking, sa CC, sa CM, pag sinabing ref temp, it's 4 degrees. Okay. The glucose level decreased by 2 milligrams per deciliter. So basically, mas mabilis magkaroon ng glucolysis sa room temp. Kapag kasi hinayaan mo, if you are not using the red top tube, kapag walang sodium chloride or walang anti-glycolytic agent, yung evacuated tube na ginagamit, mas rapid talaga yung glycolysis. One explanation, nagkakaroon ng glycolysis in vitro kasi white blood cells and other cell elements parang kinakonsume nila yung glucose. Gets ba? Yung mga blood elements, parang ina-absorb nila yung glucose, parang kinakonsume nila, especially white blood cells. Okay? Kaya meron palatandaan dito, kung alam niyo palatandaan dito na 7 rooms and 2 reps. 7 rooms, 2 reps. Okay. Sa lab daw, mayroong 7 room, may 2 rep. 7 rooms, 2 rep. Ganun yung, tawag dito yung glucose decomposition. Okay? 7 rooms, 2 reps. Okay? 10% contamination with 5% dextrose will elevate glucose up to 500 milligrams per deciliter. Saan natin encounter kanina sa may non-ketotic hyperosmolar diabetic coma. Pag ganyan yung level. Pero kung wala namang diabetes yung patient, na-admit lang kasi na-disgrasya, ibig sabihin nun, nag-collect ka sa may arm niya na merong IV line. That's why, during your internship, kapag meron ka nakitang IV line, doon sa may site for the collection, kailangan nyo muna i-stop yung IV line ng 1 to 2 minutes. Kung wala ng choice. Pero as much as possible, iwasan natin yung site or yung arm na merong IV line kasi mataas yung mga analyte. Mataas ang sodium, mataas ang electrolytes, mataas ang glucose, especially kapag dextrose siya. Yan. So 10% contamination of 5% dextrose, aabot ng 500 milligrams. So that's absurd. That's above physiologic limit unless merong diabetic coma yung patient. Okay? Malaman mo naman yan, di ba? Okay. In fasting state, results of arterial, venous, and capillary are comparable, whereas after meal, venous glucose levels are lower than arterial and capillary. Focus kayo dito. Sa venous glucose levels are lower than arterial and capillary. Same lang dito sa second statement. Because of glucose turnover. Whereas in fasting state, since equilibrated baseline, yung circulation halos pantay-pantay lang. Kaya nga, ano ba yung pinakamagandang parameter for glucose hemostasis? Fasting blood sugar. Yun yung pinakamagandang parameter pinakamagandang parameter for glucose metabolism evaluation. Fasting blood sugar, yung pinakamaganda. Kahit huwag ka nang mag-RBS, basta FBS ang pinaka-importante. Kasi nandito yung baseline. Okay? Diyan yung baseline or basal state. Yan, basal state kapag fasting. Kaya, i-disregard mo na lahat except fasting kasi yun yung pinaka-importante. Most important and most commonly requested test to determine glucose homeostasis, fasting blood sugar. Okay. May mga tanong? Wala lang tanong. Explain naman na ng mabuti. Okay. Pero gets yun naman na. Okay, by the way, announcement lang before I will end our discussion. Okay. Sa mga na face-to-face, it's your responsibility to send all the documentation sa mga corresponding GC. Okay? Kung meron kayong mga video, it's better to send all those documentation sa mga group chat para magkaroon ng idea yung mga hindi naki-face-to-face sa gagawing activity. Okay? So, ganun yung mangyayari. Okay? So, sa activity nyo, I will post the activity on Thursday and Friday. Okay? Ganun yung mangyayari. For, bibigyan ko lang kayo ng konting background about the activity. Okay? So, basically, yung activity na yun, modified siya. Modified. So, magkaiba yung activity ng face-to-face students sa mga students na hindi naka-face-to-face. Okay? Sa face-to-face students, gagawa kayo ng journal. Pero yung title ng journal nyo is activity pa din. Okay? So, lahat ng step-by-step process from phlebotomy to spectrophotometry as in lahat ng process. Okay? Pero sa mga hindi nag-online, hindi na face-to-face classes, you will draw the procedure, pero hindi na kayo magdo-draw from phlebotomy. You will start your drawing on the obtained SST sample. So basically, kapag hindi ka naki-face-to-face, ang drawing mo na lang yung extracted na blood, centrifugation, labeling, pipetting, ganon lahat. So, centrifugation, that's why. Okay? Ganon yung mangyayari. Okay? Commonly kasi, kapag ganitong mga activity, kung face-to-face kayong lahat, pinapa-journal na lang. Pero sa mga hindi lang face-to-face, mga online students, kailangan yung i-drawing para malaman niyo yung mga nangyayari during the process. Okay? So yun lang. And by the way, yung mga exempted sa quiz ng carbohydrate, dapat qualified participant. When I say qualified participant, they are on the official roster ng SCC. Okay? Kapag nag-participate kayo sa screening tapos hindi naman kayo na-qualify, hindi kayo exempted. So basically, yung mga qualified lang. Okay? And then, yung extension ng activity, ano yung last activity natin? It's drawing. So lahat ng mga participant this week, I will extend the submission of the activity on blood collection until Monday. Until Monday lang ha. Until Monday lang yung extension. for activity on blood, on phlebotomy, yan, on the Manday lang. Yan
Bakte
lang.
pa, sir.
Ano?
Bakte pa, sir.
Hindi pwede. Hindi pwede. Bakte. Hindi ko sure. Sige, tignan ko na lang. Kasi hindi naman